Okay, so hello, good day to everybody. I'm Dr. Dasit, General Surgery Registrar, second year. So today I thought of discussing about a paper that was given to ERPM students back in 2017, 17 December in the fall. So without much, so I hope that you have got the questions previously. Maybe a PDF or something containing the questions.
Yes, we got.
Okay. Let me check. Let me check. Okay. Okay. All right. So we'll discuss from the first question ahead. So the first question. So deficiency in potassium levels in our body. Okay. So what they're asking is basically hypokalemia, features of hypokalemia. Okay. So in order to uh, uh, discuss about what are the features of hypokalemia, we should understand what are the causes for hypokalemia, and what is the physiology behind it. Okay. So when we talk about causes for hypokalemia, you can categorize into three contents, three parts. For contents into cells. What we check from hypokalemia is the potassium ions in our extracellular, mainly in the plasma. So if the ions are driven into the cells by some mechanism, then the potassium ion levels in plasma is going to reduce. So what does drive the potassium ions into the urine excess? Did I sign off somewhere?
Your voice is breaking, sir.
Okay, so I'm not sure. Okay, how about now? How about now? Hello,
Now a bit fine, sir.
bit
Still,
fine.
it's a bit slow, but a bit fine.
Can understand or
Yeah, now okay, sir. Before it was breaking a lot.
is it a background noise or just
No, I think it's stucking. The connection of problem.
okay. So at the moment, all right, right?
Yes, yes, sir.
If it is breaking, just let me know, okay?
Sure, sir.
Okay. So let's discuss about where did you I disconnected?
At the
Did I
beginning, sir, about hypokalemia.
Okay, so hypokalemic causes, okay? So we can broadly categorize into three causes, okay? First is entry into cells. Second is there's losses from somewhere, either GI losses or renal losses. So those are the three causes for hypokalemia. Let's talk about the increased entry into cells. So when we check for our serum potassium levels, so what we check is the plasma amount. Now imagine the potassium ions are driven into the cells by some kind of mechanism. Then the plasma potassium concentration decreases, right? So what are these factors that drive potassium into the cells? For example, insulin excess. It could be either insulin given by either endogenous insulin or exogenous insulin. Endogenous means, example, there's a insulinoma that secretes excess amounts of insulin. Or we give insulin via exogenous route. We give subcutaneous insulin for treatment of diabetes. And that also can drive potassium into the cells. For example, we use this mechanism when treating hyperkalemia. We give dextrose along with soluble insulin as a treatment for hyperkalemia. That is to drive this potassium into the cells. Okay, and then beta adrenergic action. So that also we use salbutamol as a nebulization to induce potassium ions to go into the cells. Again, we use that as alkalosis. When the pH of the extracellular content rises, then again as a defense mechanism, as a homeostatic mechanism, the potassium drives into the cells and also in hypothermia. This is one of the few examples, that is most common examples. And then comes the upper GI losses. For the intestinal losses, it could be upper GI loss or lower GI loss. When we talk about upper GI loss, it is mostly due to vomiting. In vomiting, now if you see this, you can see these images, right? Hello?
No, sir, the screen is not visible.
You that told me. How about now?
Yes, sir, it's visible.
Okay. Okay, now what you see is in the left side is a parietal cell in the stomach, which is responsible for secreting the hydrogen ions into the lumen. Okay, and on the left side is a principal cell that is located in the distal convoluted tubule of the nephron. Okay, so what happens in excessive vomiting is that when we vomit, the hydrogen ions that has been secreted is lost. With vomiting, the hydrogen ions that is secreted in the lumen is lost. But if you see, the hydrogen ions are secreted to the lumen in exchange for potassium. So why does hypokalemia occur? There's no reason for hypokalemia. If the potassium is lost, more and more potassium, if the hydrogen is lost, more and more hydrogen will be secreted into, then more and more potassium will be absorbed into the body. Then why is this hypokalemia? That is due to when we vomit excessively, we go into dehydration. You know, when we go into dehydration, our renin-angiotensin aldosterone system that is activated, and with that, there is there's stimulation of secretion of aldosterone, mineralocorticoid, and this aldosterone acts on the principal cells in the distal convoluted tubules, where it opens up the ENaC channels, and where it acts on the sodium potassium ATPase, in which where sodium is excreted out for potassium, and this potassium is excreted out to the lumen in the kidney. So the potassium is lost actually not with vomiting, but with the urine, because of the as a compensatory mechanism for the dehydration. Okay, did you understand that hypokalemia occurs in vomiting is because of this? This is called hypokalemic hypochlorite metabolic alkalosis. Why hypochlorite? As I said, there's loss of potassium ions from the kidneys. Why hypochlorite? Now, if you see these images, in the basolateral membrane of the parietal cells, there's an exchange which exchange bicarbonate ion for the chloride. And this chloride is again secreted out in the lumen, which form the HCl, that form the acid in our body. Hydrogen plus ions with the chloride minus from the HCl. So when this vomiting occurs, all this chloride is also lost. So hypochloric, hypokalemic, hypochloric. Now we are losing H plus ions. So what happens? The bicarbonate ions increases in the body, which cause alkalosis. Now this is not a respiratory type alkalosis, this is a metabolic type. This is a metabolic disorder. So hypokalemic, hypochloric, metabolic alkalosis. This is a common, this could be a question from you as a MCQ point of view. Okay, did you understand the principle about it? Okay. So when you talk about the lower GI losses, for example, you can there are different types of polyps. Out of that, Livilus adenoma is notorious for secreting high potassium rich mucus secretions. And they secrete a lot of fluid, almost more than 1 liter of fluid per day. So when this villus adenoma secretes more and more fluid, and potassium also is lost. So in this lower GI losses, the potassium is lost as a direct mechanism. Okay, so example in villus adenoma. And then the renal losses, problems with the kidney. For example, we use diuretics, we use furosemide, which cause a lot of decreased absorption of sodium. When the sodium load to the distal convoluted tubule increases as a homeostatic mechanism, sodium is exchanged for potassium, and this potassium is lost. So diuretics, mineralocorticoid action, again, as I said, aldosterone, and renal tubular acidosis are causes for renal losses of potassium. So all of these causes cause hypokalemia. Did you understand? Okay. And then now let's go to our MCQ. Okay. So deficiency in potassium occurs due to excessive vomiting. Is it true? Yes. Yeah, like we discussed, it is due to excessive vomiting, but not directly due to excessive vomiting, but due to the dehydration. But it is true. It is due to excessive vomiting. It is a cause of paralytic ileus. Okay. I need to show you a different image for that. You know, now in our body, there are cell membranes. In the cell membranes, there are something called depolarization membrane. These are depolarized. So why is the membrane is depolarized? Because the sodium amount outside the membrane is higher than the amount of potassium that is increased, that is there in the intracellular part. So there's a difference in electrical gradient. So the inside is more negative than the outside. That is why the outside is more positive than the inside. Okay, so what happens when hypokalemia occurs? Okay, when hypokalemia occurs, what the cell does? Now body wants to keep in homeostasis, keep in a stable degree. So what does it do? There are some more potassium ions in the cells. So what does the cells does? They try to excrete some of this potassium to the extracellular fluid to maintain homeostasis. So what happened? The negativity in the intracellular compartment further reduces. So the membrane potential further decreases. For example, if it is in -70 as in this image, it will further decrease down to -90, -80. So when a current occurs, when an impulse occurs, there's something called threshold potential. So that threshold potential, for example, in this diagram is the -50. So it is difficult for the when the membrane potential is 90, it is difficult for the cell to achieve the membrane to achieve the threshold potential. Because imagine now 50 and 70, there's only 20 milli equivalent gap. But imagine it's 50 and 90, there's a 40. So the cell cannot be depolarized. So because of that, these cells does not get depolarized, and then in turn, the contraction is lost. Contraction is reduced. That is why in that is why in hypokalemia causes paralytic ileus, because the smooth muscles cannot contract, because the depolarization is difficult because of the increased electrical gradient. Did you understand what I said? Did you understand
Yes,
the question?
yes, it was understood.
Okay, all right. So yeah, that is then to our question back again. So is a cause for paralytic ileus. Yes, true. It is a very known cause for paralytic ileus. When we have paralytic ileus, serum potassium level is mandatory, and it is, if it is lower than 3.5, then obviously we need to correct. Our target is to maintain a potassium level of at least 4.5 level. So that is our target in paralytic ileus. If you know that, that is also could be asked in MCQs. Okay, causes exaggerated reflexes. Does it? Now imagine, now go back to what I said again. The muscles, the nerves and the muscles cannot be depolarized. The depolarized current cannot travel. So will the current go and produce a reflex? No, right? Because it can't, because the nerve or muscle cannot be depolarized. So the impulse cannot travel. So to where the end organ muscle. So the reflexes are reduced, right? So understood, right? Okay. So it is also false. So that is false. So then the fourth stem is characteristically causes tall T waves in the ECG. Okay. So let's look at the ECG of a hypokalemia. So these are the features of hypokalemic ECG. There's ST depression, the QT interval is prolonged, a flattened T wave, and most characteristic, the U wave. The U wave is very characteristic. The U wave usually is not found in normal ECGs, but in hypokalemia, the U wave is characteristics. But what about in hyperkalemia? In hyperkalemia, a tall tented T wave is a characteristic sign. And with increase in levels of potassium, this tall tented T wave further increases. For example, think like somebody pinching from the T wave and just lifting it up. With further lifting it up, it becomes first it becomes tall-tented T wave, and then it becomes at the end sine wave pattern. Basically like this sine wave pattern. Okay, so basically somebody has picked from the T wave and lift it up. Tall-tented T wave becomes sine wave pattern. So that is in hyperkalemia. So our answer is not correct. Characteristic tall wave ECG, tall waves are found in ECG on hypokalemia, not in hyperkalemia. It is treated with calcium resonium. Okay, so what is the treatment for hypokalemia? We have to, first of all, we have to correct the cause. Now we are losing a lot of potassium from somewhere, or we are losing potassium into the cells. So we have to correct the cause. Without correcting the cause, we can't remedy it. Whatever we do will again be lost. So we have to correct the cause. If it's vomiting, we should stop the vomiting. If it's for example, exogenous insulin, we should reduce it like that, and then go for potassium replacement. And potassium replacement also, we cannot just give boluses. We can only use this as an infusion along with with a crystalloid. Okay, all right. So what is this calcium resonium then? This calcium resonium is given in hyperkalemia. It is given orally, and then this calcium binds to potassium and reduce the calcium amount, that is potassium amount in our body. That is called calcium resonium. Calcium, that is why we call give calcium resonium. Not for hypokalemia, it's for hyperkalemic treatment. Okay. Okay. Okay, so the first question, the answers are true, true, false, false, false. Okay, all right. So let's go to the next question. Features of Horner syndrome. Okay, so what is Horner syndrome? So there are our cranial nerves. Cranial nerves have parasympathetic uh, supply, but they don't have sympathetic supply originated from the brain. So from where does the sympathetic supply comes to our body, to our face and neck? So from where it comes? From the thoracic segment of the spine. So from there, this thoracic, from especially from the T1 and T2, this segment supplies the sympathetic supply to the face. So it's form the superior, inferior, and middle cervical ganglion, and with those, from those, they supply, they send the parasympathetic nerves via the carotid artery, and then it joins the cranial nerves and up to the end organs. So what does sympathetic activity do now? Imagine there's some problem with those supply. Imagine, for example, a Pancoast tumor, a tumor in the apex of the lung that has invaded into these sympathetic ganglions, and there's a block in sympathetic supply from that point onward. So no sympathetic supply to our body. So what will happen? Results in meiosis, ptosis, and anhydrosis. So what is meiosis? Meiosis is constricted pupils. So think like this. So now sympathetic activity rises in what instances? For example, when we are feared, when we are afraid. So when we are afraid, we are not relaxed. We are very agitated, and we need more stimulus for our run or flight mode. So what happens? In sympathetic activity, the pupil should be dilated in order to let more light and exposure in. So, but when sympathetic activity lost, only parasympathetic activity is there. What happens? The pupil constrict, becomes meiosis, not dilated, meiosis. Okay, so that is why it results in meiosis. And ptosis. This our upper eyelid has elevator palpebrae superioris muscle. Now this also have autonomic supply. It also have parasympathetic and sympathetic. If there's no sympathetic supply, then the eyelids start to drop down, called ptosis. That's why it becomes ptosis. And then anhydrosis. When you get excited and all, you sweat a lot, because that is as a metabolic response in our body, you sweat a lot. So in that part, imagine if my right side is there's no sympathetic activity, then my right side ipsilateral anhydrosis, that side will not have any sweating. So other side will be wet while this side will be dry. It's called anhydrosis. And also there will be some degree of enophthalmos. That is because with the lack of sympathetic supply, the soft tissue behind the eye will atrophy to a slight degree, and which will cause our eyeball to sunk a little bit. So these four features are the characteristic symptoms of Horner's syndrome. Meiosis, constricted pupils; ptosis, drooling of eyelids; anhydrosis, lack of sweating in one part of the face. If both sides are affected, yes, both sides are affected. If only one part is ipsilateral anhydrosis and ipsilateral enophthalmos, that part there would be shrinking of the eyeballs will be shrunking, going in, rather than other eyelid going in, like that. Okay. So okay, let's go to the MCQ now. So features of Horner syndrome: unilateral exophthalmos. Is it exophthalmos? Exophthalmos is the eyeball is actually protruding out, not going in. So not unilateral exophthalmos, but unilateral enophthalmos. So it is wrong. Hyperacusis. So where does hyperacusis occurs? So hyperacusis occurs when there is damage to the cranial nerve, eighth cranial nerve. That is the vestibulocochlear nerve injury, not in Horner syndrome. Hyperacusis is very characteristic when there's damage to the vestibulocochlear or the eighth cranial nerve injury, not in Horner syndrome. Okay. And meiosis, as we said earlier, it is true, meiosis. Ipsilateral loss of facial sweating. Yes, that is what I call anhydrosis. Ipsilateral anhydrosis, that is the correct term, anhydrosis. And wasting of muscles in the dorsum of the hand. So dorsal muscles. Okay, now muscles in the dorsum of the hand is mainly the intrinsic muscles between our metacarpal bones, which is formed by the dorsalis and dorsal and palmar interosseous muscles. So these muscles are supplied by the deep branch of the ulnar nerve. Okay, so these muscles are atrophied when there's an ulnar nerve palsy. These muscles will be atrophied, and in the first web space it is by the adductor pollicis muscle, and all these muscles are supplied by the deep branch of the ulnar nerve. And if there's a cut or damage or some kind of some kind of damage to the ulnar nerve during its course, then these muscles will undergo denervation atrophy, and which will cause atrophy, and there will be dorsal guttering. These spaces which is filled with muscle will reduce, and it will become like a gutter. It's called dorsal guttering in the spaces within the web spaces. All right. So that is also false. That is in ulnar nerve palsy. Okay. Do you understand this concept, Horner syndrome and this ulnar nerve palsy?
Yes, sir.
Okay. If you have any doubts, just uh, unmute and chat, unmute and speak. Sometimes if you have just put a message, I might not see it. Okay. Until such, I will see in a later time. By that time, we will be moved from the question. Okay. So, okay. Let's go to our next question regarding thyroxine. Okay. So, MCQ. So, it should be taken soon after a meal. So, is it correct? Should we now imagine, now you are a house officer, and there's a patient who has undergone a total thyroidectomy, and now the patient is about to be discharged, and the patient will ask you, so doctor, how will I take my thyroxine dose? So how would you advise this patient? So that is what they have asked on this stem. So thyroxine should be taken in an empty stomach. Okay, so why is that? Why can't we take in an after meals? So thyroxine uh, weight absorbs, it competes with iron and calcium for absorption. Now imagine we have taken a nice good meal, or we have drunk some milk or something. Now there would be other elements also competing with thyroxine for absorption. So not all of the thyroxine that is being given to us will be absorbed. Okay, so we will be getting only a sub-physiological amount of thyroxine into our body, and some of it amount will be lost with our feces. So that is why we ask them to drink the thyroxine on an empty stomach. The best time to drink thyroxine is the when is the best time? When is the most often the best time with an empty stomach is when you wake up in the early morning. As soon as you wake up, you are almost have not eaten for around 6 to 8 hours. So the stomach will be completely empty unless you have some kind of gastric obstruction, outlet obstruction. So that is the best time to drink the thyroxine. That is why we ask the patients to drink the thyroxine when you wake up at a uniform time. It should be if at 6 a.m. the patient should be waking up at 6 a.m. and drinking at every day 6 a.m. Not 6 a.m. one day, not 8 a.m. one day, like that. At a unique time, as soon as she wake up, she drink the thyroid with a small bit of water, just a sip of water, just for the thyroxine to be swallowed, not a glass of water. Okay, and then wait for 30 minutes to 1 hour until you drink anything else, drink or eat anything else. After 1 hour, you can uh, drink something and then later eat on. So that is how you advise on thyroxine. Okay, so all right. So the stem, it should be taken as soon as a meal. So it's false. It should be taken on an empty stomach, not after meal. False. Okay. It is contraindicated during pregnancy. Is it so? No, because thyroxine is essential in pregnancy. In fact, the demand for thyroxine increases during the pregnancy, and sometimes no patients who are euthyroid during before pregnancy might get little bit hypothyroid in the pregnant period. For example, patients with Hashimoto's disease and all, they might be euthyroid during before the pregnancy. But when she becomes pregnancy, the demand is so high, the remaining gland cannot produce enough. So she might become hypothyroid. So that is because during the first one is during the first 13 weeks, the fetus is entirely dependent on mother's thyroxine for its development during the first 13 weeks of gestation. And on top of that, during the pregnancy, the thyroid binding globulin also increases, so more demand for thyroxine. Okay, so that is the reason. Okay, so it is contraindicated during no, it is necessary, and sometimes we might need to supplement this patient with levothyroxine. Suppressive dose reduce recurrence of papillary carcinoma. Okay, so in papillary carcinoma, after we have done the thyroidectomy, we give the patient a slightly supraphysiological dose of thyroxine. No, so what is the physiological dose of thyroxine in? It is 1.6 micrograms to 2.1 micrograms per kg per day. That is the range of physiological thyroxine need in our body. Depending on the body weight, it can range from 1.6 to 2.1. So we give a slightly higher supra physiological level, slightly higher. For that is given for what? To stop the pituitary gland from secreting TSH. So there's a feedback mechanism. The pituitary gland forms TSH. The hypothalamus forms TRH, and then it forms the pituitary gland forms TSH, and this TSH induces the formation of T4, free T4. So when this free T4 levels increase in the body as a feedback mechanism, it stops the hypothalamus and pituitary gland to prevent secretion of furthermore TSH, reduce secretion of TSH. So by giving more thyroxine, we stop the TSH production. We reduce the TSH production at the higher centers, namely the pituitary. In papillary carcinoma, the TSH is a stimulus for the glands to work. So with elevated TSH levels, the recurrence rate of papillary carcinoma can be higher. That is why we give supraphysiological levels of T4. That is that depends that on the patient's risk for developing papillary thyroid cancer. When a patient comes to us with papillary thyroid cancer, we risk stratify the patient according to American Thyroid Association guidelines. You don't need to know this risk stratification. How do you do it? Just need to know there's something like that, and depending on that, we adjust the thyroxine dose. So upon that, we risk stratify this patient into low risk, moderate risk, and higher risk. So low risk, our target is our TSH target is 0.5, 1 to 0.5. Sorry for the typo. It is actually should be 0.1, 0.1 to 0.5. But is high risk. It is in the TSH target should be less than 0.5 milli international units per liter. Okay, and that with time, imagine if it's low and intermediate risk, we can reduce this suppressive dose in around 2 years. But in high risk, we can reduce this suppressive dose in 5 years. Okay, so that is the principle why we give supraphysiological levels of thyroxine in papillary thyroid carcinoma patient. Did you understand this principle? Okay,
Yes, sir.
suppressive dose reducing. Thank you for answering. Reducing recurrence of papillary carcinoma, yes, that's why we give it. So you understood the concept, okay? So the daily requirement is 1.6 micrograms per kg per body weight. So it is said as 1.6 to 2.1. So 1.6, 1.5 is kind of in the low borderline. So I would in this situation, I would not answer this question, this stem, because this look a little bit ambiguous, like very uh, so now some books says, not every book says 1.6 to 2.1. The Robbins pathological basis says 1.6 to 2.1, but some places might say 1.5, 1.4. It depends on different authors. Like some in different books have different ranges. Slight difference, but different ranges, slight difference. So in this book, the person who has made this question might have referred some book and put this number. And if we have, as I have referred Bailey Robbins pathological basis, then I might say this is wrong. But to him, that book might say that is normal. So this kind of an vague. These terms, the lower borderline should not be given. It should be at least given a range. It is not a one fixed value. It is always a range of values. So this stem is also not very good stem. So now I know that I can collect 4 marks from the all other stems without answering this stem. So 4 marks I'm happy with. I don't have to go for 5 marks. So for me personally, if I went to the exam, I would not answer this stem because this is vague. I don't know what the examiner is thinking. I know a range, but he might be expecting some answer. So only he and God knows. So better to leave these type of questions. Oh, like that is a trick you should master when you go to exam. What are the type of stems in MCQ that you should leave, and what are the stems you should uh, click for? Okay, so that is a different. So the range is 1.6 to 2.1. Depending on different books, it might vary a little bit. And it should be stopped before 3 weeks of radioiodine therapy. Okay, so why do we give radioiodine therapy? Again, we re-stratify these patients according to the American Thyroid Association guidelines, and we determine low, intermediate, and high risk. For intermediate risk and high risk patients, we give radioiodine therapy. Why do we give that? We give that when we do the total thyroidectomy. There's no guarantee that all the thyroid cells are taken off. There may be few cells, few islands of cells still remaining, and those can implant and then recurrent may have recurrence of regal thyroid and cause recurrence of papillary thyroid carcinoma. So because of that, in order to kill those small uh, cells that is still deposited, we give radioiodine treatment. Okay, so by radioiodine treatment, what we give is iodine 131. 131, this cell should be able to take in this iodine and storage in them. And when they storage this radioactive iodine in their cells, this radioactive radiation will destroy the cells. But if the cells cannot take the radioiodine, the radioiodine what we give will just goes off with the urine. So there's no point giving radioiodine for this. In order for the cells to take in the iodine, the patient should have good levels of TSH. Why? The TSH is the hormone that determines the iodine uptake. Okay, so TSH determines iodine uptake. If I don't have TSH, I can't take iodine into my thyroid gland. How much I eat? So because of that, now if we give supraphysiological levels of thyroxine, as we mentioned earlier, the TSH is very, very slow. And on that note, we go into the Maharagama and we give iodine 131. Would it be any beneficial? No, the iodine will not be uptaken. So for that, we should increase the TSH levels. So there are two methods of doing that. We can either stop or reduce the levothyroxine that we are giving to the patient, or there's a new modality called recombinant TSH. Basically, the TSH that is produced and given as exogenous TSH. Okay, that's called recombinant TSH. So we give the normal thyroxine levels and prevent the patient from going into hypothyroidism, while the patient is good levels of thyroxine in blood in the plasma, we give TSH from outside, so the cells can absorb iodine. That is not readily available. So in that case, what we do? We stop the uh, thyroxine levels. When you stop the thyroxine level, the TSH gradually climbs back up. So for T4, the levothyroxine that we give, we should stop it at least 4 weeks prior to the iodine therapy, radioiodine ablation. And if it is T3, we should stop it between 1 to 2 weeks before the radioiodine ablation. But there are other regimes also where you cut off the thyroxine dose by 50% and then continue for 2 weeks and reduce. Those are a little bit beyond your level, so you don't need to know those. So you just know two methods: recombinant TSH and stopping thyroxine. Though that two methods is enough for you. Okay, that the others are a little bit at a higher level than what is expected from your level. All right. So that is why it is stopped with, before 3 weeks of radioiodine therapy. True, it should be at least stopped 4 weeks of iodine therapy. Okay. So yes, it is true. Okay. Did you understand?
Yes, sir.
Okay. So okay, yeah, okay. So as I said, recombinant TSH is given while on thyroxine uptake, the TSH level of 25 to 30 and 0.5. But what we need is almost 25 to 30. So imagine the difference. So for that, we should stop the thyroxine or give the recombinant TSH levels. Okay. Okay. So, and this radioiodine therapy is an absolute contraindication for breastfeeding and pregnant patients. Okay. So, okay. So next question then. Okay. So stridor after thyroidectomy. Sorry for the typo, thyroidectomy. So when we talk about now, when you go as a house officer, if you do a surgical appointment, thyroidectomy is one of the most commonly performed surgeries in this country. Thyroidectomy, inguinal hernia, and laparoscopic all those three you will in your routine theater lists. So after thyroidectomy, if you hear a stridor, you should be able to identify it and treat it in a rapid and efficient manner. That is a absolute must that is expected from your level, because the house officers are the persons who will be available in the ward in a 24-hour basis. So you should be able to identify a stridor and adequately manage it. Okay. So what are the causes for stridor after thyroidectomy? You can classify it in early, immediate, early, and late. So what is immediate what does cause immediate stride? For example, large multinodular goiters, extremely large multinodular goiter that has been sitting on the trachea for long term, and this long term compression on the trachea causes ischemia to the tracheal cartilages, and then these tracheal cartilages softens. They become very softened, almost like soft tissue. So because this tracheal cartilage adhere to the multinodular goiter, it does not compress, it does not collapse back. But when you take out the large goiter out, there's no more support for this softened cartilage rings. So what happens in inspiration? There's negative pressure inside the tube in the trachea. So the airway is collapsed, upper airway. So this causes respiratory compromise, airway compromise. So as soon as you remove the tube off after now you do thyroidectomy on general anesthesia. As soon as you remove the tube, the patient begins a stride, and the patient's saturation drops, and the tachycardia increases, and the patient's respiratory distress appears. So that's called tracheomalacia. Okay, that is an early cause. And also recurrent laryngeal nerve injury. Recurrent laryngeal nerve supplies the muscles of the uh, uh, almost all muscles except the abductors. Now the vocal cords are like this. Okay, the vocal cords are adductors and adductors abductors and adductors. Okay, so abductors are almost supplied by the recurrent laryngeal nerve. So recurrent laryngeal nerve, what does this is? Abduct. So there's a space between the vocal cords. But the superior laryngeal nerve, it supplies the posterior adductor. It causes adduction. It closes the lumen. So there's no airflow. So what happens? So imagine one side only, like recurrent laryngeal nerve goes, still there's only one part abductor, but the other part can be open. Still there's there'll be voice hoarseness, but no stridor. But imagine both sides that recurrent laryngeal nerve is damaged. For example, it's a very adherent thyroid cancer, like anaplastic thyroid cancer, and the what do you call the recurrent laryngeal nerve, both are cut without being known. Okay, so what happens? Both vocal cords are in an adducted position, so the airflow is not there. As soon as you take off the uh, endotracheal tube, what happens? It closes off, and the patient goes into respiratory distress. So that is also a cause for immediate stridor after thyroidectomy. This is usually noticed in the theater, not in the ward. Okay. So what will you notice in the ward? So it is either uh, it is what we call early thyroid early stridor. It is due to either primary or reaction wise when there is there's bleeding from the surgical side during the surgery. Okay, and reactionary hematoma is when there's bleeding. There's no bleeding when the surgery is closed, but the bleeding happens later on. That is, if bleeding happens in less than 24 hours from the surgery, is called reactionary hematoma. So primary and reactionary hematoma causing compression of the trachea will cause again stridor and laryngeal edema. So most of the time, the most common cause is this hematoma. So if you see a patient with a hematoma after thyroidectomy, what should you do? You should first of all prop up the patient, put high flow oxygen to this patient, humidified oxygen to this patient, and then immediately we should take this patient to the theater, and then open up the sutures and let the air evacuate the hematoma. And if taking to theater is if it is delayed, then you should remove the dressings, remove the sutures in the ward itself, because it is life threatening. We can't wait for long. The that airway could be compromised, and with this laryngeal trachea and laryngeal edema also develops, and with this the compromise would be very severe, and then patient can go into respiratory distress. So if taking to theater is delayed, then you should remove the sutures then and they are in the wound even sometimes you have to. Okay. So now when you close the thyroidectomy, you close in 3 layers. You close the deep fascia, you close the platysma, and you close the skin. All 3 layers should be opened up. Okay. So all 3 layers should be opened up. So the trachea is exposed to the air. So whatever hematoma is collected can just drain out. And then we take to the patient to theater, we wash the wound out, and we look at we evaluate the wound, and we see where the bleeding is coming from, and then we try to stop it with ligature or diathermy or clip or whatever. Okay. So that is the management of stridor in the patient with after post-thyroidectomy stridor. And late is when there's developing of seroma, and when there is features of hypocalcemia. So you know the parathyroid glands are situated in the posterior aspect of thyroid gland. So when you take it off, when you take the thyroid gland off, sometimes this easy to mislead with fat cells, fat globules, because they almost look like fat globules except for the. So if you take the thyroid, it will take around 72 hours to manifest. And with this hypocalcemia, the laryngeal edema will occur, and the laryngeal muscles will go into the spasm. So again, it can cause stridor. Okay, that is why we in the postoperative period we give calcium for oral calcium for this patient. That is fine, because even the surgery, even if we don't remove these parathyroid glands, when we handle the thyroid gland, when we try to dissect it off the thyroid gland, this can cause transient ischemia, and this ischemia can cause hypocalcemia in 72 hours. So to prevent that, we give oral calcium as prophylactic dose of oral calcium to the patient, and after 2 weeks time we can just omit it off if there's no features of hypocalcemia, and observe for hypocalcemia. If there's no features of hypocalcemia, we can just omit it off. Okay. All right. Okay. So let's go to our question. So recurrent nerve, recurrent laryngeal nerve palsy. Is it true? Yes. Neck hematoma, as we discussed. Yes. Tracheomalacia. Yes, as we discussed. Hypothyroidism. What do you think? Now, in a patient with hypothyroidism, in the hypothyroidism, we have taken this patient to the theater. This one of the characteristic features of hypocalcemia is mixed edema, because thyroxine is necessary for the degradation of protein that is accumulated in our soft tissue. If these proteins are not degraded, then there's oncotic pressure, there's plasma proteins in the blood vessels, and because of that, the water is trying to stay in the blood vessels. But when these soft tissue matrix, when they degrade, they form small pieces of protein particles. If they accumulate, then this oncotic pressure that is there in the vessels is decreased, because there's proteins outside the lumen also now, and this thyroxine is necessary for these protein molecules to degrade. If they do not degrade, then the trend of water to stay inside the vessels is decreased, and the oncotic pressure decreases, and the plasma tries to leak out. That is why it becomes mixed edema. So imagine a patient with hypothyroidism, then this patient has a high chance of developing laryngeal edema. So that's also is a true. It can also come if the patient has not adequately optimized and thyroxine level is very low, then she can develop a laryngeal edema and cause stridor. So it is not a early, it's a late, she will develop a late stridor. And hypocalcemia, as I said earlier, with our damage to the parathyroid glands, which will cause hypocalcemia, which will cause the laryngeal muscles to go into a spasm. Okay. So all the answers are true in that question. So next question. Regarding parotid gland tumors. Okay. Most common is the pleomorphic adenomas. Okay. So when you talk about parotid gland tumors, the most common benign tumor is the pleomorphic adenoma. And the most common malignant tumor is the tumors in the parotid gland are benign. Okay, because when you talk about salivary glands, there are two types: minor salivary glands and the major salivary. So, what are the major salivary glands? Parotid, submandibular, and sublingual. And what are the minor parotid glands? Palatine glands, like those. Okay, so cancers in the minor salivary glands are more likely to be malignant, but the tumors in the major salivary glands are more often benign than malignant. Malignant is little bit less occurrence than a benign condition. Okay, okay. So most common is pleomorphic adenoma. Is it correct? Yes, it is the most common. So enucleation is the treatment for pleomorphic adenoma. So when you talk about pleomorphic adenoma, it usually presents between the third to sixth decade of life, and the mean age is at around 45 years of age. The incidence is little bit more in females than males, and almost 80% of this pleomorphic adenomas occur in the parotid gland. Okay, and they present in the clinic as plainless, well-defined solitary nodule. A plainless, well-defined solitary nodule that is mobile, that is not attached to anywhere. It's just a painless lump, and it grows progressively and it progressively enlarges, keeps enlarging. Okay, sometimes it enlarges to massive decrease. Okay, and the enlargement itself can cause special necrosis of the skin. Okay, so that is a pleomorphic adenoma. And most of the time, this pleomorph now you can divide the parotid gland into two parts: deep and superficial. So the superficial part is what gives origin to the most of these pleomorphic adenomas. But sometimes it can be developed in the deep part also. If these glands are developing in the deep part, then you sometimes you will not feel the large tumor growing. Instead, it will grow inside to the mouth. In the inside of the mouth, you will see a bulge going into, because it's deep, because it grows inside to the mouth. You can, and you open the mouth, you can see a bulge coming inside, and it can also cause pressure to the facial nerve and cause facial nerve palsy. Okay, and one thing to remember is malignant potential is very rare, and if there's malignant transformation into adenoma, then facial nerve palsy will be there. So imagine the patient coming with features of pleomorphic adenoma, and there's facial suspicion whether this is a malignancy. Okay, okay. So let's go to the question, and let's go to treatment also. So when you talk about treatment, the treatment choice is superficial paroidectomy. So what we does is we take out all the parotid gland superficial to the facial nerve. Now you know the facial nerve enters into the parenchyma of the parotid gland and divides into two branches, anterior and posterior, and then ultimately divided into five branches: temporal, zygomatic, buccal, marginal mandibular, and cervical. So those are the five branches of facial nerve. So what we so the parotid gland superficial to the facial nerve is called superficial part, and the deep part is called deep. So in the superficial paroidectomy, what we do is we preserve the facial nerve and take out all the parotid gland that is superficial to the nerve. So that is the treatment of choice for parotid gland pleomorphic adenomas, because most of the time 80% the gland tumors are from the superficial part. But if it's imagine if it's a deep part, then sometimes we may have to go for total paroidectomy, either with conserving the facial nerve, or sometimes we may have to sacrifice it and later reconstruct with different other nerve grafting. Okay, but now our question is, enucleation is the treatment for pleomorphic adenoma. So what is enucleation? So basically enucleation means is if there's a lump, we just dissect around it and take it off. If there's a lump and a capsule, we just dissect around it and take it off. That is called enucleation. So if we do enucleation in this pleomorphic adenoma, it will cause now this pleomorphic adenoma. If you look at the histology, there are slight pseudopods forming in the like pseudopods. You know what pseudopods, right? So forming in the margins. So if we enucleate it, we will go through these pseudopods. Okay. Now, if we go through this pseudopods, there will be tumor spillage and there will be incomplete resection. So this can cause local recurrence again. So enucleation is no longer the treatment for pleomorphic adenoma. It is superficial, conservative superficial. It's called conservative superficial parasectomy. Okay. Okay. So most are from the so that is false. So most are from the superficial gland. That is true. Benign tumors are commoner than malignant. Yes, as I discussed, benign are more common in major salivary glands, and parotid gland is a major salivary gland. In benign, facial nerve involvement is common. Is it? No, as I said earlier, if there's facial nerve involvement in parotid gland tumors, then we should suspect something is problem, because in in malignancy, and rather than benign, the tumor is trying to invade into structures, invade and infiltrate, because it has the ability to invade into other areas. That is why it's called malignant. So now in a benign, it does not invade. It just grows in. It just grows out. It just grows out in a wide front. But in malignancy, it can invade, like pierce into other structures. So imagine now a malignant nodule invading into the facial nerve, then it will cause facial nerve palsy. So we should have a high suspicion it could be a malignant tumor of the parotid gland. So in benign facial nerve involved common, that is false. Okay. Regarding submandibular gland. Okay. Surgery can damage the buccal branch of the facial nerve. Now there are 5 branches of the facial nerve. One is temporal, other one is zygomatic, other one is buccal. Buccal is what supplies our buccal muscle and the risorius muscle. It goes like this. And then comes the marginal mandibular muscle. So the submandibular submandibular gland is located in the submandibular triangle. Okay. So in that triangle lies the marginal mandibular nerve under the skin. So that is at risk, not the buccal branch. And then the other branch is cervical branch, that is innervating the platysma. That is not really encountered. That is not encountered in submandibular salivary. Only the cervical, marginal mandibular nerve is involved. So if you damage the marginal mandibular nerve, there will be like this. The affected part will be like this. There will be dropping of the angle of the mouth like this. Okay. So that is false. Okay. Hypoglossal nerve is close to the gland. Yes, there are 3 nerves that is close and related to the gland. One is, as I said, the marginal mandibular nerve. The other is a lingual nerve. Lingual nerve is actually wraps around the duct of the submandibular gland. Let me show you a picture. So you see, now this is the can you see my cursor? Can you see the cursor moving in the image?
Yes, yes, sir.
Okay. So now this is the submandibular gland. Okay. And this submandibular gland has 2 parts. This is the mylohyoid muscle, superficial part and deep part. Deep part, just like it's like gland is like a sea. It goes along like this. Okay. And from the deep part origins the submandibular duct. So this is submandibular duct. Okay. This mole white part is submandibular duct. So the lingual nerve across the submandibular duct, and we approach the deep part and we ligate the gland. Sometimes this nerve can be damaged, so we have to be careful about it. Okay. So that is lingual nerve, and then there is the hypoglossal nerve. If you see this, there's a lingual nerve and the hypoglossal nerve. The submandibular gland will be around here. Now this is submandibular gland, and submandibular gland will be around here. So the lingual nerve and the hypoglossal nerve is in near vicinity with the submandibular gland. So all these 3 nerves are in near vicinity, and in the surgery we should be careful not to damage. Okay. And this is the branches that I said to you earlier, the branches of the facial nerve, the frontal or frontal branch, temporal or zygomatic branch, buccal branch, marginal mandibular, and the cervical branch. Okay. Okay. So, okay, that is true. So stones in the gland can be extracted through the oral cavity. Now, when you talk about the submandibular gland silolithiasis, submandibular gland is the most common type of cellular gland to have stones. Why is it? Because there's a inborn defect in thyroid in this anatomy of this gland. Because this gland, the gland's duct is it has a very long course and it ascends against the gravity. Now, example, it's in the floor of the mouth and it comes to the mouth. It ascends against the gravity. So it has to, it doesn't drain along the gravity, it has to go against the gravity. So what happens? So the secretions try to stagnate, right? It doesn't drain, it doesn't try to drain, it try to stagnate. So what happens when things stagnate? It gets so it gets stagnate because calcified. Okay. And this, and another thing is this, the secretions of the submandibular gland is called mucinous, not serous. If it is serous, then it is not very thick. The viscosity is very like water. But in mucinous secretion, it is very viscous. It is again, that also is difficult for drain. Imagine now, example, if you pour water, water will just flow off. What if you put oil? Pour oil. Oil will take little bit more viscous, so it is difficult for to flow. What if you put something like honey? It won't go, it will take further more, right? Like that. When the viscosity increases, the flowing also reduces. And on top of that, the saliva is kind of alkaline. So there's high chance of it become calcium precipitation is higher. With all these three factors, that is why the submandibular gland has a high chance of developing sialolithiasis. So if there's a MCQ, this can give question as a MCQ from you. So these are the three causes. And almost 80% of these stones are radiopaque. And the treatment options, they are depending on whether the stone is in the gland or the duct, the treatment options are different. If it is the gland and depending on the size also. If it is the gland, then if it's a smaller size, we can do a endoscopic stone removal. We can find the opening of the submandibular gland under the tongue, and then endoscopically go and take the gland, take the stone out is less than 5 millimeters. But if it's more than 5 millimeters, then close the duct. And what happened? What about intraparenchymal stones? Depending on the location. If it's a large one and kind of deep, then intraoral approach would be not possible. But imagine if it's almost at the duct, but intraparenchymal, and there's a smaller duct, we can use endoscopic as well as ESW. What is ESW? Endoscopic shock wave lithotripsy. Okay, so we use sound waves to break the stones and make it small and take parts out. So even it's in the gland, there's a chance that there's a opportunity that we can use what do you call oral route to remove it rather than doing surgery and taking out. So imagine if a large stone that is difficult to take, then obviously the option is to go for surgical resection of the gland. That is called salivary. But again, now this is a little bit a sensitive topic. Now, stones in the gland can be extracted through oral cavity. Now, imagine this question is made by a very senior surgeon who at that time, what the principle was, if in the duct decision. But now the treatment has changed a little bit. Now imagine this MCQ is formed by a very senior surgeon who has who practices that pathway. Then he might be expecting you to mark this stem as false, because in the gland you have to do salivectomy. You can't do the, so he might be expecting that, but in the books it might say different thing. So it is again a little bit ambiguous. So in this question, I know again that I can score 4 marks with the other MCQs and leave this MCQ B. So I can score 4 marks while leave this stem B. So I would rather just leave this stem B, but according to it can be taken out, but depending on the circumstances. Okay, depending on the circumstances, it can be true, but some surgeons might take it as false. So understand the principle, and the most important is understand the principle, not the what do you call me, the MCQ. Okay, all right. So majority of stones are radiopaque. As I said, 80% is radiopaque. The commonest salivary gland present with the calculi. Yes, as I said, the reasons are, as I mentioned, long course of duct that is ascending against the gravity, mucinous secretions, and alkaline saliva precipitating calcium easily. So that is the, so I can easily get 4 marks and leave that small stem out. So that's fine. That's all acceptable, right? I can get 4 marks and just leave the stem out. We don't have to get 5 marks from all of it, right? Okay. Okay. Did you understand this thing about salivary gland tumors and nectomy and the salolithiasis?
Yes, sir.
Okay.
Yes.
So, all right. Then comes our next question regarding ulcerative
Sir,
colitis. Yeah,
sir, can you repeat the answers?
answers. Okay. Last question, right? So,
Yes.
submandibular gland, right? So surgery can damage the buccal nerve of the facial nerve. False is the marginal mandibular nerve. Hypoglossal nerve is close to the gland. True. Stones in the gland can be extracted through oral cavity. As I said, it's ambiguous. But in as per the book and what I read, it is true. But I would rather just leave it be because of that issue I told you. Because some people might not expect as we don't know who made this question. So it might be very senior surgeon or maybe early surgeon, young surgeon who has read this read this more often. So according to the books and all, it's true. Okay. There's some degree of truth depending on circumstance, depending on the duct gland stone size, and depending on where the stone is. Imagine if just at the just at the deep part, then there's chance it might be able to take up through endoscopic retrieval with shockwave therapy, lithotripsy. And majority of the stones are radiopaque is true. Uh, Most salivary gland to present with calculi is the submandibular gland. It's also true. All right.
Thank you, sir.
Sorry.
Thank you, sir.
Okay. Okay. All right. So next question is regarding malignant tumors of the testis. Okay. So when you talk about testicular cancers, it is around the incidence is around 1% of all male cancers. And when you talk about the classification, we can broadly classify into germ cell tumors, which is the most common type of testicular malignancy that we encounter, is almost 95%. That too we can divide into seminomas and non-seminomas. Non-seminomas also we can divide it again into teratomas, choriocarcinoma, like that. And then the other is the, sorry for the typo, sex cord cell tumors like Leydig cells, Sertoli cell tumors, and then lymphomas and other types of tumors like metastatic tumors. Okay. When we talk about seminomas, it is almost seminoma is the most common of out of all these malignancies. It's almost 50% out of the germ cell tumors. And when you look at them, it's very, you can have, they have very characteristic feature, pinkish creamy homogeneous appearance. It's like a pink cream. Like imagine you take a pink cream and dehydrate and form into lump and cut it. It's like that. It's homogeneous, no, just a pink cream material. And hematogenous spread is uncommon, while lymphatic spread is the most commonest to the para-aortic lymph nodes. Okay. And non-seminomas, the types are embryonal carcinoma, yolk sac tumors, teratomas, and choriocarcinomas. Those are the types of non-seminomas. You can broadly categorize germ cell tumors into seminomas and non-seminomas. And then comes the other tumors such as sex cord cells, and lymphomas and others. Okay. So when we talk about the diagnosis, when a patient presents to us, we first do the clinical examination and the history taking. In the history, they will say about a planeless testicular lump that is growing in size. Pain testicular lump that is growing. Okay. And if there is pain, that could be due to a torsion or hemorrhage in the hemorrhage within the malignancy. Hemorrhage, there's a hemorrhage with that, in the malignancy, the center becomes sometimes necrose when the center necrose. Sometimes the blood vessels also can exert pressure and cause pain. Okay, and sometimes now we know one of the etiology for hydrocele are also testicular malignancy. So if the patient comes with a lax hydrocele, then again we should have suspicion this might be a malignancy, so we should examine the testis properly. If we can't, then we should order ultrasound scan to diagnose. And if it's already metastasized in the abdomen, we may see lymphatic masses. And if it's a metastatic lungs, sometimes it could be asymptomatic. Some kind of patient will come with respiratory distress features as well as hemoptysis. So those are the clinical features they come with. So when we examine the patient will be a hard, like a firm lump with the associated hydrocele. And on abdominal examination, we might sometimes feel if there's lymphatic mass, we might see lump, and we have to auscultate the lungs also. Okay. So when you talk about the diagnosis, we can the diagnosis confirmed with the ultrasound scan, and then we have to take other protein, beta HCG, and LDH prior to the surgery. Later, after the surgery, we can read. Did somebody ask something? Anybody ask something? Okay, yeah. Just don't feel afraid or anything. Just if you have something, just ask. It's all right. So you can just ask. No worries. Okay. Uh, 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 okay. Whatever, right? So okay, we can redo these markers and assess if we have adequately resected or not. Okay, so imagine we have resected and there are still undiagnosed lymphatic mass within the abdomen, then the tumor markers will not decrease. But if this is the primary tumor and we do a radical inguinal logidectomy, then the tumor marks will decrease in around 48 to 72 hours. And also we should do a chest X-ray prior to look for cannonball mets in the lungs. Okay, and we stage this testicular tumors with a CT, chest, abdomen, and pelvis. And again, and we stage into 3 categories: stage 1, 2, and 3. 1 is non-metastatic, 2 is a lymphatic nodal metastasis, 3 is distant or nodal metastasis with elevated biochemical markers. Okay, so that's how you stage it. We stage the CT, abdomen, contrast in CT, chest, abdomen, pelvis. Okay, and when you talk about treatment, these are most commonly these patients are young adults, less than 40 years. The peak incidence is at 40 years, so we should offer them, if the family is not complete, we should offer them semen analysis and sperm banking, which is available in some places in Colombo now. And then the treatment option is after staging surgery plus neoadjuvant adjuvant chemoradiotherapy. The surgery is radical logidectomy. We are an inguinal incision, not a scrotal incision. It's an inguinal incision. Why is that? Because the lymphatic drainage of the scrotal skin is different and the testis is different. Testis drains to the para-aortic lymph nodes, but this what do you call this? Scrotal skin drains to the inguinal lymph nodes. So if we breach this scrotal skin and take off the testis, then there will be tumor seeding into the scrotal skin, and this will be metastasizing into the inguinal nodes. So it is absolutely mandatory that we don't do that. Okay, so that is why it is important to completely exclude the possibility of malignant testicular tumor before operating on those hydrocele and other lumps, varicoceles, we have to exclude the possibility of mainly in hydrocele, not in varicoceles, sorry, mainly in hydrocele, to exclude the possibility of a malignant testicular tumor. If we have that, we can't do a transcortal incision. All right. And seminomas are both chemo and radiosensitive. Non-seminomas are chemosensitive. And stage 2 and 3 disease, both radiotherapy and chemotherapy can be given, but radiotherapy is preferred because, chemotherapy is preferred because radiotherapy has this problem with cardiac morbidity. Okay, so let's go to our MCQ. Okay, so malignant testicular tumors usually occurs before the age of 40. Yes, it is occurring. Peak incidence is in fourth decade, as well as now in non-seminal germ cell tumors, it's between 30 to 40 years is the most common age. So it is true. Usually resistant to radiotherapy? No, it is actually they are sensitive to both chemo and radiotherapy. Staged by abdominal CT scan. Yes, it should be chest, abdominal, and pelvis, all three, but staged by abdominal CT scan, you can take it as correct. But ideally, it should be chest, abdomen, and pelvis, all three. So metastatic disease is mostly incurable. Now, this again is a vague stem. Now, testicular tumors have a good prognosis, and even stage 2B is we can go with curative intention with neoadjuvant therapy and surgery. So again, this stem could be taken as true also, because metastatic tumors most of the time it will present as in a very high metastatic state. So again, it's a difficult stem to comment on. My answer would also be like true, but some degrees, like example stage 2, we can go with curative intention also, because testicular tumors have a good prognosis other than other tumors. They generally have a good prognosis. So, but now when in stage 3 with lung metastasis, then obviously it would be incurable. So depending on the stage, it could be it should be a multidisciplinary meeting, and we should decide on the course of treatment. We can't just say it is incurable. There are different stages. So mostly incurable, a bit difficult to comment on. Some are incurable, some are we can early stage metastasis, we can try with curable intention with neoadjuvant chemotherapy and chemoradiotherapy and surgery, and after that again adjuvant chemoradiotherapy. Okay, so again I would leave the stem B because other stems are very easy to mark and I can easily get 4 marks. So commonly metastasize to inguinal nodes. Is it true? I explained the mechanism by how testicular tumors metastasize via lymph nodes, because testis is supplied by the via the so the lymphatic so how does the lymphatic accompany? They accompany the arteries. So the arteries or the arteries to the testis origin from where? Directly from the aorta. So these lymphatic channels also directly go to the paraortic lymph nodes. But the skin, scrotal skin, is draining to the medial group of the inguinal lymph node group. Medial group. So if you breach the skin only, there will be tumor seeding, and then there will be tumor metastasis to the medial group of the inguinal nodes. But otherwise, there would not be. Okay. Okay. So the answers are true, false, true. Can take it as true and false. Okay. Regarding, so did you understand?
Yes.
Okay.
Yes.
Okay. So, okay, next question regarding ulcerative colitis. Okay. So so when we talk about ulcerative colitis, it is one of the inflammatory bowel diseases. Okay. So ulcerative colitis is different from Crohn's disease by several reasons. For example, ulcerative colitis starts from the rectum and spreads proximally as a united front. Okay, spreads in the starts in the rectum and spreads proximally as in the united front. But in Crohn's disease, it's not like that. It's a patchy disease. It's why it's called cobblestone disease. Patches, and it can involve anywhere in the intestine. It can involve the colon, the small intestine, distal ileum, the mouth, esophagus, anywhere. It can involve anywhere. But most is in the terminal ileum and the right side colon. But it can involve anywhere. So, but in contrast, ulcerative colitis occurs in the rectum and spreads proximally. And the extent, now imagine we get a cross section of the intestine, and the involvement of the wall in ulcerative colitis is only in the mucosa layer. Only the mucosa layer is involved up to the basal membrane. But in Crohn's disease, the entire layer, it's a transmural involvement, not just mucosal, transmural. It involves all the way through the serosa. That is why in Crohn's disease, they call fistula formation. But in ulcerative colitis, they do not call fistula formation. All right. Okay. And rectum, it starts in the rectum and ascends proximally, and sometimes the entire colon can be involved. If the entire colon is involved, there could be some degree of terminal ileum also involved. It's called backwash ileitis. Now, in this MCQ, there's one thing called pseudopolyps. So, what is this pseudopolyps? So, when this when this entire a sheet of mucosa is involved, but some parts like small islands of mucosa might be spared. So in a sea, now imagine like this, in a sea of damaged mucosa, small islands of intact mucosa are preserved. Now those are called pseudopolyps. So what is pseudo? Pseudo is something like false, not true, but false. Pseudopolyps. That is why it called pseudopolyps. They are not polyps. They are just islands of normal mucosa that has not been affected by the ulcerative colitis. So it is normal islands of mucosa in a sea of affected mucosa. So that is why it called pseudopolyps. Okay. So is the normal mucosa is a pre-malignant lesion? No. No, it's just normal mucosa. So if it's pre-malignant, no, that is false. Okay. So, and the other thing is ulcerative colitis has a higher risk of developing cancer rather than Crohn's disease. Why? Because ulcerative colitis can cause polyps, and there's a there's a concept called adenoma carcinoma sequence. First, you develop an adenoma with accumulation of mutations. It develops into carcinoma, and it takes a long time. It accumulates mutations and it develops into carcinoma. That's called adenoma carcinoma sequence. Now it takes around 8 to 10 years for adenoma to develop a carcinoma. So that is why after diagnosis, now with the diagnosis from the diagnosis of the ulcerative colitis, the duration increases, the chance of having a malignancy also increases, because more time goes, more chance for the polyps develop and become malignant. So in around 10 years of diagnosis of a polyp, chance of malignant on background of ulcerative colitis is 1 to 3%. Okay, that is okay, so it increases. So that is a big question. Sometimes it's not. It will be advanced for you, but if you know this name, that would be a higher. That would be a good point if they ask in the sequence. Okay. So, and what are the intestinal manifestations of ulcerative colitis? It can involve the hepatobiliary system, such as primary sclerosing cholangitis, fatty liver, autoimmune diseases, musculoskeletal system, peripheral arthritis, ankylosing spondylitis, osteopenia, osteonecrosis, dermatological system, like pyoderma gangrenosum, erythema nodosum, ocular system, uveitis, episcleritis, hematopoietic system, the venous and arterial thrombosis, pulmonary parenchymal lung disease, and airway inflammation. Let's go to our question. So most commonly involved in the rectum, yes, it start in the rectum and as proximal. Transmural in ulcerative colitis. Pseudopolyp malignant, as I said, pseudopolyps are just islands of uninfected mucosa. So those are not malignant, those are just normal mucosa. False. Has a risk of colon cancer? Yes, obviously. Uh, uh, this is an extra intestinal manifestation. Yes, it is an extra intestinal manifestation. It can cause peripheral arthritis along with Crohn's disease also. The audio is lagging. How about now? Still lagging?
Yes, sir.
Is it still lagging?
Yes, sir.
Okay. Is it all right now?
Yes, sir.
Hello? Now okay, right?
Yeah.
Okay. All right. Okay. So let's go to the next question. So when you talk about head injury, okay. So let's look at the answers first. Lucid interval is a characteristic
Sir,
feature.
can you repeat the answers for the previous question?
Sure. True, false, false, true, and true. Okay. Now remember in this MCQs, it is not actually the answer. Now I know that you want to get the correct answer. That's a different story. More than focusing on the correct answers, focus on the principle. No, I'm not saying that asking for answers is wrong. Of absolutely, you should do that, because if you don't know the answer, then it's wrong. But just focus on the principle also, because if you know the principle, when you go to the exam and they give an MCQ, you can always work it out. Now imagine if you just remember an MCQ and go to the question paper. Imagine they twist it and give. Sometimes you might not be able to work it. Sometimes you will remember the old the MCQ that you have by hearted, and you will tick it as a false, as a wrong answer. So understand the principle. If you know the principle, however they whack the question, you can whack it in return and you can get good marks. Okay, that is the ultimate goal that you should be working for. Okay. All right. So did you got the answers? True, false, false, true, true. Okay. All right.
Yes, sir.
All right. Okay. So head injury. Let's go. So let's look at the MCQs. The stems. Lucid interval is a characteristic feature for SDH. Minimum GCS 3. Biconvex characteristic for EDH. ICP is characterized by tachycardia. SDH is due to venous blood pooling. Okay. Lucid interval is not a characteristic feature of SDH. It is a characteristic feature of extradural hematoma. So what is extradural hematoma now? This is a extradural hematoma. So it's like a lens, okay? Like a lens lesion, hyper enhancing lesion that looks like a biconvex lesion. That is characteristic for EDH. When this injury occurs, initially the patient will lose his consciousness, and then he will return back to normal. He will be normal for some time. That is because of the compensatory mechanisms of our Monro-Kelly doctrine. You know, like when there's a space occupying lesion within the head. Now the cranial wall, there's a fixed volume. You can't increase that volume. Okay, so there are few components within that volume. The brain is there, the CSF is there, and the blood is there. So and the brain volume is a constant. You can't just reduce, but you can reduce the CSF volume and the blood volume. So when a space occupying lesion, something foreign comes into this cranial vault, what happens? It takes space. So in order to compensate, the CSF and the blood try to drain out of the cranial vault and stop prevent the compression of the brain. But there's a limit of this compression of this space occupying lesion. Finally, there will be a point where when the CSF and the blood cannot cope up with the increasing mass. So at that point, the brain will start to compress. For example, in this picture, you can see or the right hemisphere is almost compressed, and there is some degree of midline shift. Sorry, left hemisphere is almost compressed, and there's some degree of midline shift. So ultimately, this patient will go into damage to the brain. Not clear, sir. I see. Okay, can you give me a few seconds? I will adjust my Wi-Fi and come. How about now? Now is it clear?
Yes, sir. Okay.
Okay.
Okay, sir.
Okay. If it keeps being unclear, I will just turn off my video. I think my video is not making a good like very important. So if it keep getting unclear, just let me know. I'll turn off my video. That will, I think, will stop the lagging. Okay. Okay.
Yes.
Now you can see that ADH photon.
Yes.
Yes.
Okay. Okay. Sorry. Okay, so I was discussing, yeah, at some point, this compensatory mechanisms will stop, and that will lead to compression of the brain and lead to herniation, namely the uncal, tonsillar, and compression of the what do you call our oculomotor nerve. Okay, so yeah. And now this is the GCS score. Now, as I think everybody knows, we assess patients the GCS score. How and there are three components: motor, vocal, and eye. Motor is there are six six marks. I there are 3 marks, while vocal there are four. Sorry, I there are 4 marks. What do you call vocal there are 5 marks. So altogether it becomes 15. Okay. So the maximum is 15, but the minimum is not 0. It is 3. If the patient is basically dead, does not open eyes to anything, does not speak anything, does not do any movements, then it is 1, 1, 1. That is 3. Even a dead person will have a 3 of GCS. Okay. Okay. Just remember that is very important. Okay. Okay. Lucid interval is characteristic in EDH. Sorry, SDH. No, it is in EDH. It is very characteristic. The patient will initially have some degree of neurological deficits like a faintishness, unconscious, vomiting, and then the patient will have a period of a relatively okay level. She will be awake again, conscious, speaking, eating, and then out of nowhere he will suddenly deteriorate. And we should catch this. We should catch this and treat this patient in the lucid interval. If we wait until the deterioration part, that means the brain has already exceeded beyond its limit of uh, homeostasis. So there's no more compensation. Now the brain is herniating. At that point, if we try to intervene, it will be most likely useless, and the patient's brain will be already dead. So we should catch the patient in the lucid interval and treat it accordingly. It's very important. We can save lives with this if we catch these patients in the lucid interval. So it is false. Minimum GCS 3, yes, it is true. So biconvex is characteristic for EDH. Yes, as I said, this is the biconvex lens-like appearance in a mass, hyper enhancing mass, hyperdense mass, sorry, not hyperdense mass. Okay. In SDH, it will be a crescentric like this. It should be crescentric, like the Pakistan flag, like crescent, like that, half like crescent moon. Okay. ICP is characterized by tachycardia. Okay, so ICP, there's this thing called Cushing's triad. One thing is the patient will be high blood pressure, and in response, the patient will be having bradycardia and irregular respiration called Kussmaul's respiration. Okay, so why hypertension, bradycardia, and irregular respiration. This is called Cushing's triad in increased ICP. Now, if you see a patient with head injury and having a high BP and low pulse rate and little bit irregular breathing, like this, then it should be you should have a small doubt whether this patient, you should have a doubt whether this patient is in Cushing's triad. Okay. Okay, and SDH is due to venous blood. Yes, in EDH it is due to the, now if you see this image, you can see there's a fracture in the skull. Now in this particular area, the middle meningeal artery is almost within a tunnel in the skull. So if there's a fracture involved in this area, then this middle meningeal artery also can get damaged, and it's an artery. So it will have arterial bleeding. So it will just expand. It can't be stopped. It will expand because the blood pressure is higher than the intracranial hypertension. So when the intracranial hypertension and blood pressure equalize, the brain is almost gone. So it will keep expanding. But in SDH, it's the other way around. It's venous bleeds. Most often is the venous bleeds. So it will accumulate as a crescenteric margin. So it depends. In most of these chronic SDH patients who this old people who presents after many falls, it is due to disruption of the bridging veins. But in patients who coming with SDH after trauma, it is again due to the vessels on the damage to the vessels on the superficial, on the surface of the brain. So along with a little bit of a contusion of the brain also, there in traumatic SDH. But in chronic SDH in patients with recurrent falls like arches and CERs, then it is it is venous bleeds. Okay. So SDH is to venous bleed, that is also true. So answers are false, true, true, false, true. Okay. All right. Next question. Cellulitis. So when you talk about cellulitis, that is an suppurative infection. It could be suppurative or not. It is infective inflammation of the soft tissue component. So base up from the skin up to the deep fascia, the soft tissue are involved in cellulitis. It is an infective inflammation. Okay, the most common culprits are the Streptococcus pyogenes and the Staphylococcus aureus. Those are the most common culprits. And the risk factors are patients who is immunocompromised with diabetes, obesity, and other penetrating injuries. Those are risk factors. Okay, so when we talk about the treatment, and we diagnose it in a clinical, it's a clinical diagnosis with features of inflammation. And when you talk about treatment, there are three questions that we should ask. First is why this cellulitis occur? Okay, and why, and is this the first time? Okay, that is the first question that we should ask. Then our question is how to treat this cellulitis. How would I treat it? Then the third question is how will I prevent this patient getting further episodes of cellulitis? Okay, now these three questions are the things that we have to answer. If we answer this question, we have the management in our hand. So why does this patient get maybe the patient has a fungal infection of the skin, or there's some skin breach, there's a penetrating injury, prick injury, there's a callosity in the foot. So there should be an origin point for the infection to come into the soft tissue. Okay, so why did this occur? Is the patient having diabetes, uncontrolled diabetes? And if it is so, we should treat it. So why does the patient got it? And then treat it. Treat with antibiotics, elevate the limb, analgesics. If any skin disorder like tinea infection, fungal infection, eczema, psoriasis, then treat it. Optimize the patient's comorbid like diabetes. We should optimize that. We should get the blood sugars under control. Okay, and then to prevent it. To prevent it, we should prevent further episodes of cellulitis occurring. Why? Because with further episodes of cellulitis, the lymphatic channels that brings us the lymph back into the body gets damaged and sclerosed. If progressively more and more lymphatic channels get damaged and sclerosed, what will happen? It will develop lymphedema. And this lymphedema is a fluid with high amount of proteins, and this is a good medium for bacteria to grow. So recurrent cellulitis is an problem. It will occur. So this is a vicious cycle. Lymphedema causes cellulitis. Cellulitis causes again lymphedema. More lymphedema. Again, more lymphedema will cause cellulitis. More cellulitis will cause more lymphedema. It's like a vice versa. Like it will just spiral, and go further. So we just break the cycle. In order to break the cycle, we should prevent the lymphedema. Okay. So how to prevent the lymphedema? We apply compression stockings, massage, lymphatic massage, and prophylactic antibiotics, and elevate the lymph. So those are the prophylactic measures to prevent lymphedema. So if we answer these 3 questions, then we can manage cellulitis. Okay, let's go into the question. So effective management in acute, in lower limb cellulitis, elevation. Yes, we should elevate the limb when there's edema. To reduce it, we should elevate the limb. Compression. Okay, now this is a tricky part. Okay, now in acute cellulitis, there's no compression is not indicated, because there's no point of putting compression on a cellulitis, because there's active inflammation going on. Despite we putting the compression or not, the exudate will develop despite, and by putting a compression, we increase the tissue compression. The exudate will anyway form, and this will compress the small vessels, and this can cause ischemia to the side. Okay, so compression is in acute setting absolute no, but in prevention, after the acute lower limb cellulitis, in prevention, yes, you can have compression stocking. So now what they have is to effectively manage lower limb cellulitis. So in cellulitis setting, no, but to prevent further getting cellulitis in lymphedema, yes. So I here would not mark this as true. I would mark it as false. But I don't know who made this question, so I don't want a negative mark and my correct marks getting reduced. So I would just leave it be compression, because I don't know what the examiner wants. Theoretically, it is not. This is wrong, but this is a little bit doubtful, because some surgeons do compress, even though it is like the evidence is, there's no strong evidence to say. Now we practice on evidence-based medicine, so that is called research and evidence. So there's no proper evidence to say that compression will worsen the cellulitis or not. There's mixed evidence, so there's no proper guideline. Some people likes to compress, some people does not like. For example, the unit I worked in, we usually keep cellulitis open for the exudate to just drain out. We don't compress, but some units do compress. So I would just leave it be without marking, because I have one question already answered with I'm getting a mark. Let's go to next one, antibiotics. Yes, obviously for lower limb cellulitis, antibiotics are one of the hallmark treatment we should do. Massaging. Now massaging again is a preventive method to prevent lymphedema, not to treat acute cellulitis. So it's for cellulitis. So again, that is wrong. So I would mark it as false. Ice packs. Now Now there's already ongoing inflammation. Now applying ice packs on it to reduce inflammation is not applicable. If you put ice packs, this can sometimes this ice pack itself can cause skin burns. Ice can cause, if you keep ice for long term, that can cause skin burns. That's called frostbites. Okay. So imagine if you make another frostbite over an area that is on cellulitis, then we are creating another wound there. So that hinders our ability to treat it. Okay. So would I want to do that? No. Then I don't want ice packs. What we just keep is we elevate the limb, give the analgesics, antibiotics, optimize the comorbidities. If there's a skin disorder, we treat it. That is how you manage it. Okay, so ice packs is an absolute no. So the answers are now I can get answers with elevation true, antibiotics true, massaging again a little bit controversial. I will leave that. When ice packs true, so I can get 3 ice pack false. I can get 3 marks out of this 5. I'm happy with 3 marks. I don't want to go marking out the compression and massaging. Even though I know compression and massaging are false, I will leave it be while I get the 3 marks. Do you understand?
Yes, sir.
Hello. Okay. So hallmark in management of acutely managing the cellulitis, antibiotics, elevation, treating the comorbidities, analgesics, and treating if there's any skin disorders. Okay. Okay. Let's go to the next question regarding sinuses and fistulae. Okay. So high output fistula is characterized by loss of intestinal fluid in excess of 200 milliliters per 24 hours. What do you think? No, it is more than 500. Okay. So more than 500 milliliters per day is considered as a high output fistula, not 200. And that pilonidal sinus is a pre-malignant condition. Okay. So what is a pilonidal sinus? So pilonidal sinus is it's a condition of the natal cleft, mainly in the region of the coccyx. So there's multiple points of discharge, and these multiple points are connected together by fibrous. There's a lot of fibrosis, and this can cause infection and cause discharge. So why does this pilonidal sinus occurs? There are a lot of theories. For example, these pilonidal sinuses are found in hairdressers. Barbers and hairdressers. They have this pilonidal sinus in their like sometimes they have pilonidal sinus in acquired pilonidal in the dorsum of the web. That is because hair implantation. They regularly cut hair and always hair just gets in touchy hair. Sometimes those hair can get implanted, small hair pieces, and called pilonidal sinuses. Like that, in patients with a lot of hair, patients with hirsutism, and these hair rubbing in the natal cleft, sometimes they can go penetrate into the skin. So the hair, basically, if the skin is like this, hair is penetrating into the skin and going in, and the end of the hair is going into the skin, and this can cause pilonidal sinuses. So even sometimes when we excise this pilonidal sinus, it can recur. So what we advise these patients to, after excising the pilonidal, keep the area completely completely trim it, or even shave it, the area. Do not let the hair grow back again. So when they sit and all, the hair tries to go back again. So that is the management. Okay, and carcinoma in this region is extremely rare, and recurrence is very common after excision. Okay, now let's look at the MCQ. It's pre-malignant? No, it is not pre-malignant. It's carcinoma in this region is extremely rare. An example of a congenital fistula is a thyroglossal fistula. Okay. Now, thyroglossal sinus is a congenital sinus. That is true. But what is thyroglossal fistula? So basically we'll understand what is a fistula. So fistula is a connection between two epithelialized surfaces. So sinus is a connection it's not a connection, it is an extension, it is a blind ending tube extending from a epithelialized surface. It's a blind ending. But fistula, it connects two epithelialized surfaces. For example, enterocutaneous fistula, the stomach, the epithelial lining in the bowels is communicating with the skin epithelial lining, enterocutaneous fistula. Like that, thyroglossal fistula is a fistula between the thyroglossal tract and the skin. So when does this occur? Thyroglossal, there is thyroglossal cysts. This cyst has a high chance of getting infected. That is why we do surgery to remove those. Because the chance of them developing a malignancy is almost 1 to 5%. But we remove this routinely is because there's a chance of this developing infection. Almost 60% chance during the lifetime. If they develop infection, they form a fistula. It's difficult for us to resect it, and even we resect it, the chance of recurrence is high. So this fistula, thyroglossal fistula, is not congenital, is acquired following an infection. Basically, thyroglossal cyst gets infected and it ruptured out and form a fistula. Got the idea? So it is not an congenital fistula, it is a acquired fistula. Got it? Understood?
Yes, sir.
Okay. And non-dependent drainage is one of the factors leading to persistence of sinus. Yes. So imagine now there's a collection. It's periodically draining out. It will form a sinus. Now imagine this collection is easily drained. Entire thing is drained out and is completely healed. The sinus will automatically close off. But if that collection is not draining properly, for example, it has to drain against the gravity, then some part of it will not drain. Unless we actively drain it, it will not drain. So sinus will, so part of will drain and part will collect. Again, it will accumulate. At some point, again the sinus will form back and relieve some of the collect. And again, some of the collection will be leaving back. Again, the sinus will disappear and appear sometimes back again. Okay, so non-dependent drainage is a factor for sinus. Yes, it is true. Did you understand? Hello?
Can you explain
Yes.
that again?
Yeah. So imagine now there's a collection. Okay. Now it is draining against the gravity. So imagine now the gravity is like this, but it drains against the gravity. So when it drains against the gravity, so imagine now this collection develops, and there's compression. With this compression, when there's too much compression, the accumulated fluid will somehow find a least resistant pathway to drain somewhere. For example, if you have pressure in some compartment, it will try to release the pressure, like in a pressure cooker. Okay, so they will form a sinus along the least pressure pathway and drain, but they are draining against the gravity. So as long as there's a pressure in the collection, it will drain. Once the pressure reduces, the draining will stop. But will that collection drain completely? No, it is draining against the gravity. But imagine if it's draining with the gravity, then you don't need pressure. It will just drain out. Okay, did you understand that?
Yes,
Hello?
understood.
So if that collection is a small bit remains and the sinus closes off, that small bit will again accumulate and increase. And then again pressure will come to a point that it will go to the least resistant pathway and form the sinus again. And again it will discharge up to some degree and some will left alone. And again like a vicious cycle, it will keep happening. That is why non-dependent drainage will lead to persistent of sinus. So when we do an abscess, IND of an abscess, we always look at the dependent position and we put the incision like that. For example, if the patient is, imagine there's a thigh abscess and the patient is a walking patient, not a bed-bound patient, then we will put an incision vertically, because then the abscess can easily drain. But imagine the patient is a bed-bound patient, then we'll put a incision horizontally, because then the patient will be always on the bed and the draining will be toward the posterior side, not the inferior side. So it will drain easily. Did you understand? So entire thing will drain out. Okay.
Yes, sir.
All right. So a chronic subarachnoid abscess can lead to memory fistula. Yes, it can. It is true. Okay. Chronic inflammation and abscess is a known factor for causing fistula and sinus. Okay. Triple A. So what is triple A? Abdominal aortic aneurysm. Okay. So the incidence is around 2% of the population, and it is more common in. Yes. Am
Can you
I
tell the
breaking up?
answers again?
Yeah. So high output fistula is more than 200 is 200 is false. It's 500. 500 cyst is premalignant, that is also false. An example for congenital fistula is also false. It is acquired. Non-dependent drainage is one of the factors leading to persistence of sinus. That is true. A chronic subarachnoid abscess can lead to a memory fistula. Again, true. Okay.
Thank you, sir.
All right. So when you talk about triple A, so what is triple A? Aortic, abdominal aortic aneurysm. It is the usual incidence around 2% of the population and more in males. Why more in males? The risk of smoking. Smoking is a high risk of developing aortic aneurysm. So more in males. And out of this 95% are infrarenal. You know, when the abdominal aorta comes, it gives different branches. First of all, it gives the celiac branch, then it gives the superior mesenteric, then it gives the renal branches. So infrarenal and suprarenal. Infrarenal aortic aneurysms are the most common. So it is almost 95%. Okay. So depending on the size, the AP, anterior posterior diameter of the aneurysm, we decide to intervene or not intervene. So imagine the aneurysm is less than 5.5 centimeter. The risk of it rupturing during the patient's lifetime is 1%, unless it expands. Okay. So less than 5.5 centimeter aneurysm risk of rupturing is almost 1%. But imagine we do a laparotomy, midline laparotomy, the mortality rate is almost 5%. So to treat a 1%, we are taking a risk of 5% mortality by laparotomy. Because of that, we don't do aortic aneurysm. We repair aortic aneurysm only above 5.5 centimeters AP diameter. Did you understand? Did you
Yes,
understand
sir.
that
Yes,
concept?
sir. Yes.
So more than 5 centimeter, the risk of rupture is almost 5 to 10%. So doing a laparotomy is justified in this patient, because if the aortic aneurysm ruptures, the patient dies. You can't uh, unless the patient is in the theater. Even in the theater, unless the patient is anesthetized and ready to open the abdomen, the patient most likely would die if there's a rupture of rupture and there's intraperitoneal bleeding. The patient is most likely die. 99% the patient will die before we can intervene. Okay. So if more than 5.5 centimeters, we intervene. So the question is more than 6 centimeters requires surgery? Yes, the indication is 5.5 centimeters. Leaking aortic aneurysm mimics ureteric colic in elderly. Is it true? Yes, it is one of the differential diagnoses for ureteric colic. One dissecting aneurysm, dissecting aortic aneurysm is a indication. Leaking aortic aneurysm is a differential diagnosis for ureteric colic, especially in elderly people. So you should remember that. Okay, and always examine the abdomen to look for pulsatile masses in adult individuals claiming ureteric colic type of pain. Lump which transmits pulse. Okay, lumps can either be pulsatile or it can be just transmitting a pulse. So what is this? Let's look at a photo. So the image on your left is where the basically there's an organ in front of the aorta. So the pulse is transmitted to the organ, and that organ is moving up and down. So that is called a transmitted pulse. So only if we palpate on top of the abdomen, we will see. we will feel that part. But what if we feel that the abdomen like this, if we palpate like this, yes, then we will feel abdomen pulse. But what if we feel like from the sides? Then we won't feel, because the transmitted pulse is here, but we won't feel. But in a true pulsatile mass, it expands radially. It expands radially. So if we just keep on the sides, yes, we will feel the abdominal pulse. That is called pulse expansile pulsatile mass. The other one is called just a transmitted pulse. So lump that which transmits pulse, what does it aortic aneurysm do? Abdomen. It does not transmit pulse. It's a true expansile pulsation. So it's false. Okay. So true, false. Sorry, true, false. Most commonly below the renal artery, yes, 95% infrarenal. So it is also true. More common in males, as I said, because of the smoking risk, the most common involved is the males. It is also true. Okay. So, which of the following are true about diverticular disease? Okay, diverticulosis. So, diverticular disease in the GI tract can be divided into acquired or congenital. Okay, so acquired is when the only the muscular coating is not there, only the serosa is there, basically. But in acquired one, all three of the muscle cord, the serosa, mucosa, and the muscularis, all three are there. For example, so what are these examples for congenital diverticulum? For example, Meckel's diverticulum. For example, 2 feet from the ileocecal valve in 2% of the population, 2 inches in length. Meckel's diverticulum is a remnant of the intestinal-vitelline duct. So that is a example for what do you call congenital diverticulum. But imagine sigmoid diverticulosis. That is example for acquired diverticulum with different mechanisms. This diverticulosis has happened. Okay. All right. So when you talk about acquired diverticulum, most commonly it is located in the left side of the colon, most commonly. But there's an exception in Southeast Asia region where it's most common in the right side. We don't need to know that. That's just for this completion sake I put. You only need to know most commonly diverticulosis affect the sigmoid colon. Okay, why is it? Because sigmoid colon is narrower than the other segments, and with increased pressure in the abdomen, in the intraluminal cavity, there is herniation of mucosa through the penetrating arteries of the muscle wall. So there's a muscularis mucosa. No? There are penetrating arteries from the serosa towards the mucosa. So when there's high pressure, these penetrating points, through the penetrating points, mucosa can herniate out, and it can cause a diverticulum. Okay. So the etiology is mostly we see in the Western culture, where a lot of refined diet is used, a lot of refined diet where fiber diet is very low, processed food, which causes hypomotility and intravenous pressure, where the mucosa herniates through the size of penetrating blood vessels. So clinical features, it can cause diverticulitis, profuse painless hemorrhage, abscesses. It was a perforation and peritonitis, and these abscesses and perforations could be classified with Hinchey classification. There are 4 grades. First grade is a developing phlegmon. Second is a formed abscess. Third is purulent peritonitis. Fourth is fecal peritonitis. So that is complications of classification of complications of diverticulitis and fistula formation. They can form fistula with the surrounding organs. For example, colovesical fistula, the colon to the bladder, colovesical. Uterine fistula, so from the colon to the uterus. Colovaginal fistula, from the colon to the vagina. Like that, different type of fistulas can occur with diverticulitis. Okay, and diagnosis is done by we can do it plain X-ray. Sometimes plain X-ray won't show anything, and CT is the gold standard, and colonoscopy also possible. But if there's acute injury, acute diverticulitis episode, we wait until at least 6 weeks following the episode for colonoscopy, because there's a high risk of perforation. Okay. And the management. When you talk about the management, the hallmark is laxatives and high fiber diets and analgesics. That is the hallmarks. And if there's diverticulitis, yes, we need antibiotics. And depending on the injury classification, we might need to go for image-guided drainage, such as percutaneous guided drainage or laparotomy. But if you do laparotomy in acute setting, there's again the risk of doing a laparotomy mortality in laparotomy. So we have to weigh the risk and benefit and do in these patients, because most of these patients will be frail elderly patients. So imagine a patient is septic shock with grade 4 purulent peritonitis. We don't want to do a laparotomy unless the patient is fit. So we have to decide. And if we are doing a laparotomy, what our options are: Hartmann procedure. So you know what Hartmann procedure is, right? So we resect the segment of affected sigmoid colon, and we just clip the distal stump, we just clip stapler and just put it down, and with the proximal stump we take it as a colostomy. So that is called in Hartmann's procedure. And later when the inflammation and everything settles, we can anastomose it. And if it's an elective surgery to remove the diverticulosis segment, then we can obviously go for end-to-end anastomosis depending on patient characteristics. If the patient is healthy, good albumin level, good HP level, fit patient, ASA 1, 2, yes, of course, we can do an end-to-end anastomosis, but in elective settings, not in emergency settings when there's purulent or frequent peritonitis, because then the chance of anastomotic leakage is high. Okay, that is why we do the Hartmann's procedure in emergency setting. Okay, did you understand that part? Because that is important in obstructed colorectal carcinoma also. This Hartmann's procedure is something that you should know. Okay, did you understand the concept behind the Hartmann's procedure?
Yes, sir.
All right, good, very good. All right, so yeah, let's go to the MCQs then. Cause massive rectal bleeding? Yes, it can cause profuse bleeding. Commonly affect the cecum? No, it mainly affect the sigmoid colon, because sigmoid colon is the, as I said, the narrowest part of the colon, and usually by the time the feces come into the sigmoid colon, they are hardened, and because of this hardened feces, the motility of these feces is low, so they tend to accumulate. With accumulation, the intraluminal pressure increases, and these mucosa try to herniate through this penetrating vessel sites. Low residue diet is recommended? No, it is an etiology for diverticulosis. So what we need is a high residue diet. Has malignant potential? No, diverticulitis is rarely causing malignancies. False. Steroid is used as a treatment. We don't need, there's no point giving steroids to a patient with diverticulosis, but we need these two laxatives, high fiber diet analysis. If there's diverticulosis, yes, then there's indication for antibiotics. So true, false, true, false, false, false. Okay. Only the first answer is true. Okay. Now question number 14. Now this is a little bit important topic. Elderly patient presents with 5 days after right hemicolectomy and primary anastomosis. Patient is febrile and blood culture is positive for gram-negative coliforms. Which of the following indicates severe sepsis? Okay, now this question paper is given to you in 2017. Okay, now the treatment and diagnosis and management of sepsis is depends on the surviving sepsis guidelines. It's called surviving sepsis guidelines. It has the surviving sepsis guideline has been introduced in 1997 or 4, as I remember, and over the time it has been evolved, and the latest edition is published in 2021. Okay, so earlier the concept was there's an entity called SIRS, systemic inflammatory response syndrome, and if with SIRS there's evidence of infection, is called sepsis, and then there's severe sepsis depending on the organ dysfunction, and then there is septic shock if the MAP is more than 75 and there's rise in lactate levels. So, but in 2018, these concepts were changed. That is why this is 2017 paper. That is why these concepts are still old. So it changed. Now there's nothing called systemic inflammatory response syndrome and severe sepsis. It is just sepsis and septic shock. There's no SIRS and sepsis shock. Now in this question that they have asked is severe sepsis and SIRS. So let's talk about first about SIRS and septic shock, and then answer the questions and talk about what is defined now as sepsis and septic shock. Okay, so SIRS, as you can see in this image, there are few criteria: temperature, respiratory rate, heart rate, and white cell count. If 2 or more is there out of these 4, then it is called then we can call it SIRS. And if we can demonstrate a focus of infection with these features, then it is called sepsis. Okay, so temperature less than less than 36 or more than 38. It could be hypothermia or hyperthermia. Sorry for the typo in this this thing. So it could be hypothermia or hyperthermia, more than 38 or less than 36. Respiratory rate more than 22. Heart rate more than 90 beats per minute. And white cell count of either leukopenia or leukocytosis. Leukopenia less than 4,000, or leukocytosis more than 12,000. So that is the SIRS criteria. And then let's go have a look at this severe sepsis guideline. So severe sepsis is sepsis plus at least one sign of organ dysfunction. So what are the organs? It would be cardiovascular. Sepsis induced hypertension, systolic blood pressure more than 90, MAP less than 65. Sorry, not 75. MAP is more than 65. And systolic blood pressure. Now imagine the patient patient is a hypertensive patient. Now, do we wait until the patient's blood pressure drops less than 90 until we call it organ dysfunction? No. Imagine the patient usually has a high blood pressure of 180. Now the patient's pressure is 110. Now is that hypertension? Yes. That is patient's normal blood pressure has reduced. So SBP reduction of SBP more than 40 from the normal baseline is also defined as organ dysfunction, cardiovascular dysfunction. And serum creatinine, kidney, renal function, serum creatinine more than 2, urine output less than 0.2, 0.5 milliliters per kg per hour for 2 hours, bilirubin levels more than 2, platelet counts less than 100,000, INR more than 1.5, prothrombin time more than 60 seconds, lactate more than 2 millimoles is indication features of severe sepsis. So either one of these with sepsis is called severe sepsis. Okay, let's just have a look at this MCU now. Okay, so pulse rate 100, BP 90/60, WBC 15,500. So this patient has two features of SIRS. What is that? Pulse rate more than 100 and WBC more than 12,000. So SIRS criteria is completed. Then what about severe sepsis? Is there any organ dysfunction? Yes, the patient's blood pressure is 90, SBP is 90. So there is features of cardiovascular compromise. So first term is true. Did you understand how I worked out the answer? Hello, did you understand?
Yes, sir.
Before I go it, okay, perfect, good, very good. So because SIRS, there are two features of SIRS plus one feature of sepsis, severe sepsis. Okay, okay. So pulse rate, pulse rate 100, respiratory rate 22, temperature 38.5. Okay, so now this patient has three features of SIRS, but no features of organ dysfunction. So is it severe sepsis? No, it's just SIRS. Okay, so that is false. Next one, pulse rate 100, respiratory rate 22, serum creatinine 2 milligrams per deciliter. Now this patient has two criteria of SIRS, pulse rate 100 and respiratory rate 22. Okay, and there's creatinine level of 2 milligrams per deciliter. So that actually tallies with one features of organ dysfunction. So this patient is having severe sepsis. Okay, then now third stem is true. Fourth stem, pulse rate 100, respiratory rate 22, INR 2.3. So again, this patient has two features of SIRS, pulse rate and respiratory rate, and one feature of coagulopathy, INR more than 1.5, 2.3. So there's evidence of organ dysfunction, coagulopathy. So this patient also having severe sepsis. Fifth patient, pulse rate 100, respiratory rate 22, WBC 15,400. Now this patient again has three features of SIRS, but no feature of organ dysfunction. So this patient is only having SIRS, no severe sepsis. So the answer is true, false, true, true, false. Did you understand?
Yes.
But now this severe sepsis and SIRS is no longer there. It is an outdated term. I know some people still use this, but it is actually outdated. We should be updated in our clinical practice, and this out no longer it is documented in the surviving sepsis guidelines. You can go into the surviving sepsis guidelines. If you can just search surviving sepsis guidelines in the internet, you will go into the site, and they have the PDFs for free download. And if you have free time, you can just have a look and see 2021 is the latest guidelines, and they say they no longer it's SRS and sepsis, only septic shock and sepsis. So how do you manage sepsis? How you diagnose is with the SOFA and Q-SOFA. Now this is the SOFA score. SOFA score again, we have different criteria: respiratory, coagulopathy, liver, cardiovascular, central nervous system, renal, and we grade it according to 0 to 1, 0 to 4. If this patient gets more than 2 score, then this patient is having severe sepsis. Sorry, sepsis. Okay. Now this SOFA criteria has lot of investigations. Now imagine now we have to do full blood count, we have to do ABGs, we have to do bilirubin levels. We can obviously check the cardiovascular status without any problem, and GCS also without any problem. And this renal serum creatinine. Now these investigations take time. Now we can't wait for investigation to treat, because this is an emergency. We can't treat urgently. We have to give 3, take 3. Okay, we have to give antibiotics, fluids, inotropes, and take blood cultures, ABGs, and counts. Sorry. So we have to treat urgently. We have to give the antibiotics. So for that, they have devised a bedside score called Q-SOFA. It's called quick SOFA. Quick SOFA. That's called Q-SOFA. So we evaluate the hypotension part, altered mental status, and tachypnea. If hypotension less than 100 millimeters mercury SBP, yes, then this patient could. That is one part. Altered mental status, GCS less than 12, tachypnea, respiratory more than 22. If two or more of these criteria are there, 2 or more, then Q-SOFA is suggestive of severe sepsis and poor outcome. So we need to start our antibiotic and treat fluid resuscitation as early as possible. Okay, that is why they have developed the Q-SOFA, because SOFA takes time to evaluate. By the time we evaluate the SOFA, the patient might be dead on the sofa. So we have to evaluate the patient quickly. So because of that, we have devised this Q-SOFA criteria. Okay. Okay. So that is the new criteria. Okay. So the questions that will come in the coming exam papers will not question you on severe sepsis and SIRS, but focus on the Q-SOFA. But learn those also. As I said, there are some older surgeons who might not be aware of the new guidelines and will be asking you over the older guideline. But if you are aware of those concepts, then you are safe. Okay, so that's why I explained to you both the scenarios, the question scenario and the current setting. Did you understand? Hello?
Yes, sir.
Yes.
All right, good. Let's go. Good, very good. Let's go to the next question. Pre-malignant conditions of esophagus. So tylosis. So what is tylosis? It is a condition where there are palmar and sole skin sclerosis, and this is an autosomal dominant condition that is associated with high risk of esophageal squamous cell carcinoma. Okay, so that is the hereditary cause. Yeah, so that is true. It's a premalignant lesion. Plummer-Vinson syndrome. It's also called what do you call me? Esophageal web syndrome. It's a rare disorder characterized by iron deficiency anemia, salivary difficulty called dysphagia, and presence of esophageal webs, like thin membranes. It's called esophageal webs, and this also has a high risk of causing esophageal squamous cell carcinoma. That's also true. Barrett's esophagus. So what is Barrett's esophagus? It's a proximal migration of columnar epithelium. Now we know the esophageal epithelium is squamous epithelium, but the stomach epithelium is columnar and cuboidal, and intestinal epithelium is columnar. So if the squamous epithelium is converted into columnar epithelia, it's called metaplasia. So metaplasia of columnar epithelium for more than 1 centimeter above the GOG junction is called Barrett's esophagus. So that has a high risk of adenocarcinoma of the esophagus. This condition is associated with esophageal reflux. With the chronic reflux and chronic esophagitis, there will be metaplasia of columnar cells as an adaptive reaction. Okay, because the squamous cell epithelium is not adequate to handle acid of the stomach, so they need to convert to columnar. It occurs as an adaptation, but it is harmful for the body. It can convert into a malignant condition. Achalasia, yes, achalasia. What is achalasia? It is the inability of a segment of the esophagus, distal segment of the esophagus, to relax. That is because the inhibited ganglionic cells in the myenteric plexus in the esophagus is lost. So the muscles are in a consistent contracted tone. It is unable to relax. So in peristalsis, you contract and relax. So there's no relaxing, only contraction. So whenever you eat, there's the footballers won't travel further. It will stay above. So once you eat more and more, there's pressure. With the pressure, the esophageal will open, but not with intrinsic fact. Not from that opening is not because the esophagus is opening on its own. Because of the pressure, it just opens up. Okay, and then the fluid will pass and it will close again. And that food passing will also not be complete. Some parts will be remaining. Okay, so again, achalasia cardia is a risk factor for squamous cell carcinoma, and it can cause both squamous cell and adenocarcinoma, but more towards squamous cell carcinoma. And also scleroderma is a risk factor for squamous cell carcinoma of the esophagus. These pre-malignant lesions of esophagus you will have to then remember as a list. Yeah. Okay. So acute pancreatitis. Okay. Yeah, acute pancreatitis. Let's look at the questions. Cirrhosis is a cause caused by gallstones. CRP level is directly correlated with the disease severity. Pancreatic cirrhosis is a complication, leads to chronic pancreatitis. Pancreatic surgery may be required in severe cases. So, what are the causes for acute pancreatitis? So, if you can remember, there's a mnemonic called "I get smashed." Right? So, if you just have a look on that. I also can't remember exactly what the specific I get smashed is. If you just go and have a look in the internet, you get I get smashed. Those are the etiology. So all this etiology are summarized in this picture. But I get smashed, you can just easily remember it with a pseudonym. So the most common etiology, what is it? Is either alcohol or gallstone. This is the most common etiology for pancreatitis. Okay, just remember that alcohol and gallstone. Apart from that, there are a lot of other reasons: post-ERCP, abdominal trauma, following biliary or upper GI surgery, ambulatory tumor, drugs such as corticosteroid, azathioprine, asparaginase, valproic acid, thiazides, estrogens, hyperthyroidism, hyperparathyroidism, hypercalcemia, hypertriglyceridemia, pancreatic divisum, sphincter foci dysfunction, autoimmune pancreatitis, hereditary pancreatitis, viral infection, malnutrition, scorpion bite, and idiopathy. So idiopathic is the last stage. If we can't evaluate, if we can't find any of the etiology above I mentioned, then only we diagnose as idiopathic. So if you go according to I get smashed. I actually forgot to post that. So let me check. I get smashed. So this is I get smashed. Okay. So it is easy for you to remember. Idiopathic, gallstones, ethanol trauma, steroid use, mumps, autoimmune, scorpion stings, hypercalcemia and hypertriglyceridemia, endoscopic retrograde cholangio ERCP, and drugs. Okay. And this I actually not just idiopathic, it is idiopathic and inheritant and inherent. Idiopathic and inherent also. Okay, not just idiopathic, also idiopathic and inherent, such as pancreatic divisum and causes like that. Okay, okay, understood.
Yes, sir.
All right. Okay, so let's go to the question. Cirrhosis is a cause? No, cirrhosis is not a cause. Caused by gallstone? Yes, it's one of the commonest cause. CRP level is directly correlated to disease severity. So when it comes to pancreatic severity assessment, there are lots of scores, Ramson score, Apache scores, it was a CRP score. There are lot of scores. Lot of scores. When you have lot of scores for one disease, that means none of these scores are perfect, because all of these scores has deficiencies. That is why there are lot of type of scores. Some scores assess the local severity, some scores assess more with the systemic severity, like that. Like that, there's a score depending on the CRP also. So if CRP level after 2 days and 48 hours after diagnosing acute pancreatitis, if the CRP is more than 150, then the severity is high. Okay, then the chance of it's a high severity index. Okay, so that is what this they have asked in this question. CRP more than 150 milligrams per liter at 48 hours from onset is an indicator of severity. Okay, and pancreatic pseudocyst is a complication. So yes, then when you talk about local complications, it can broadly classify as uh, uh, peripancreatic fluid collection and acute necrotic collection. Okay, the fluid collection is just some exudate fluid accumulating in the around the pancreas. Acute necrotic collection is there's necrotic pancreatitis and the part of the pancreas and the surrounding tissue is necrosed. And from this point, after 4 weeks, we call acute peripancreatic fluid collection as pancreatic pseudocyst, because there's a with inflammation they have created a wall around that fluid collection. Now it's called pancreatic pseudocyst, no longer peripancreatic fluid collection. And in acute necrotic collection, it's called walled off necrosis. Again, around the surrounding the necrosis, they have created a wall to separate the necrosis from the normal body. So it's called walled off necrosis. Okay, so that is how you identify name the local complications. Okay, so you can divide the complications of pancreatitis into systemic and local. Systemic, it could be divided into depending on the organ: cardiovascular, pulmonary, renal, hematological, metabolic, GI, neurological, miscellaneous, everything, anything can happen. Most commonly cardiovascular shocks and pulmonary ARDS, and renal failure is the most common. And then comes the DIC and the metabolic parts. And local, like as I said earlier, peripancreatic fluid collection, pancreatic necrosis. And this pancreatic necrosis can get infected also, Hari. Then it cause infected walled off necrosis or infected acute necrotic collection. If it's necrosis, then the patient's systemic complications will rise up very fast. Can easily go into septic shock. And infected peripancreatic collections has a very high mortality rate. Okay, and other such as pancreatic ascites, pleural effusion, again more for local systemic complication than local. and pseudoaneurysm along the pathway of the renal splenic artery and splenic vein, splenic artery. So those are local complications. Okay, so pseudocyst is a complication. Yes, it is true. It's a local complication after 4 weeks of the acute attack. Leads to chronic pancreatitis. Yes, if there's recurrent acute pancreatitis, it can convert into chronic pancreatitis. It is true. Pancreatic surgery may be required in severe cases. Yes, if there's recurrent pancreatitis, and that will need surgery, either to remove a necrotic segment, or if there's duct obstruction with multiple calculi to relieve the obstruction, then we can do pancreatic surgery. Those you don't need to know by name. If you just know surgery is the last option, either to relieve obstruction or remove segment of necrosed infected segment, then that is enough. Okay, the pancreatic surgery could be done either laparoscopically or open, retroperitoneally or midline laparotomy. So that is, if you can remember that, that is more than enough. All right, understood? So the question answers are false, true, 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 true. Okay. All right. Next question regarding villus adenoma. So when you talk about villus adenoma, there are different types of adenoma. Sorry.
We have this 16.
Sorry.
16 question.
Did I miss it?
Yeah.
Yes. Constipation. Sorry. Very sorry. Let's go to the constipation. Okay. Causes of constipation. Okay. So what are the how can you divide the causes of constipation? It could be a GI, it could be a problem in the intestine, or it could be a systemic problem that manifests as a that is a that part of the manifestation is a constipation, or it's a problem with the GI tract. So what are the problems with the GI tract to cause constipation? There could be obstruction somewhere. Either it could be a benign pathology or malignant pathology. An obstruction causing so the feces can't move forward, and it causes constipation. So rectal carcinoma is a known cause for constipation. Okay, so like that. Functional disorders such as megarectum, Hirschsprung disease, such as that. It also cause constipation. So you know what Hirschsprung is? So there's a segment of aganglionic colon. So that part will not undergo peristalsis, and therefore there's no constipation. There's no feces coming through that segment. So they will call constipation. Those are called functional obstructions. And then metabolic medical causes such as metabolic disorders. There are electrolyte disturbances that will cause constipation, such as hypercalcemia, uremia, hypokalemia, hypomagnesemia, hyponatremia, like that. Endocrine disorders, hypothyroidism is a very common cause for constipation. Diabetes and pregnancy, because diabetes diabetes can cause it can cause neuropathy, and this neuropathy can affect the autoimmune parasympathetic autonomic pathways, and this can reduce peristalsis and cause constipation. And neurological disorders such as degenerative CNS disease such as multiple sclerosis, drugs such as opioids, anticholinergics, calcium channel blockers, and some psychiatric drugs, antidepressants like TCCS, psychological disorders such as depression, eating disorders, cognitive behavioral disorders, and others such as connective disorders and causes of immobility. So all these causes can cause constipation. This is how you characterize. Those last causes, like others are not very important, but these drugs, psychological again not very important, but depression is a very common cause for constipation. You should know it. You will encounter a lot of patients in OPD settings with depression, with constipation. They will come with constipation, but actually they might be depressed. If you treat that, then this constipation also improves. But a lot of these patients get missed, diagnosis get missed, and sometimes they end up in long-term laxatives, which will not benefit that much in these patients. So it is important for you to remember metabolic disorders, endocrine disorders, and other GI causes that you should remember. So let's look at the questions. Hypocalcemia. No, not hypocalcemia, it is hypercalcemia. The hypercalcemia, that is what causes constipation, because it reduces the colonic motility. Hyponatremia. What do you think? Hyponatremia, does it cause? Actually, sorry, it is hypernatremia that cause constipation, not hyponatremia. Okay. Okay. So hyponatremia is false. Hypothyroidism, yes. Common feature of hypothyroidism is constipation. What will cause hyperthyroidism? They will have diarrhea. They will have liquid diarrhea. And hyperkalemia may, again, no, it's false. It's hypokalemia, not hyperkalemia. And uremia also true. So false, false, true, true, sorry, false, true. Okay. False, false, true, false, true. Okay. Put here, put the message. So question number 16. Yeah, sorry. Yeah, that's why you put the message. Don't put the message because I might not see it. So I will see it later on. So if you just speak up, then I can. It's okay. You understood. So causes of constipation, if you can classify like this, then you are done. Okay, acute pancreatitis we discussed. Villus adenoma. Most commonly occur in the cecum? No, it most commonly, villus adenoma is common in the rectum actually. Commonly seen in the rectum, yes, true. It is a cause for rectal bleeding, yes, it can cause rectal bleeding, and also it can cause profuse mucus discharge, which is very highly rich in potassium. It can cause hypokalemia, which if you can remember the first question, the causes for hypokalemia, I said lower GI losses. One of the etiology is villus adenoma. It can cause a lot of potassium-rich fluid secretions, which is lost and cause hypokalemia. It is a cause for hypokalemia. Yes, it is true. It has a higher malignancy potential than tubular adenoma. Yes, of course. Villus adenoma has a higher risk of malignancy than tubular adenoma. It is treated by endoscopic excision. Yes. The options for treatment is depending on the size of the villus adenoma. If it is smaller, then obviously we can do it a snare polypectomy, either hot or cold. If it is larger, then we will have to go for techniques such as endoscopic mucosal resection or endoscopic submucosal dissection. And if it is very large, then we will have to go for other surgeries like endoscopic transanal endoscopic microsurgery. And if that fails, then we will have to go for surgical excision, surgical resection of the rectum. So those are the surgical options. So treated by endoscopic excision is a treatment modality that is true. Okay. Did you understand? Okay.
Yes, sir.
Okay. So treatment model polypectomy, EMR, ESD, transanal endoscopy. You don't need to know where do we do EMR, where do we do ESD. If you know there are options like this, that is enough at your level. All right. Okay. So the next question. Which of the following are end arteries? Okay. So right hepatic artery, digital artery in the middle finger, penile artery, superior rectal artery, and the appendicular artery. So what are end arteries? So end artery is a terminal artery that that does not anastomose with any other collateral arteries. It basically it supplies part of an organ or finger or some organ that is the only blood supply for that part. So that something happens to that or artery, then that supplied part is also going to die because there are no collaterals to that part. Did you understand? That is why it's called an end artery. End artery. There's no anastomosis to that artery, and then no collaterals. If there's something happens to that artery, that supplied part also will die. Okay, now let's look at what are the end arteries. Right hepatic artery. Yes, it is a right hepatic artery supply the right lobe of the liver. So imagine now we are doing a laparoscopic cholecystectomy, and we accidentally we damage the right hepatic artery in the Callas triangle. Right? So what will happen in the what will happen? The entire right side lobe will get necrosed. Okay, so there's no blood supply other than the right hepatic artery. Maybe some part will be survived from the caudal arteries and all, but most of the segment will die off because that's the end artery. So that is true. Digital artery of the middle finger. Yes, digital arteries are all end arteries. That is true. Penile artery. Yes, again, that's an end organ artery. Again, if it's blocked, then again it will cause ischemia to the penis. Superior rectal artery. Now this is false. There are three arteries: superior, middle rectal arteries in about 20% of the population, and the inferior rectal artery. So all these three arteries are anastomosing together. So even if we take the superior rectal artery, the inferior rectal artery might be able to supply the blood supply. So it's not an end artery. Okay, so it is false. Appendicular artery, yes, again it's an end artery. It is an continuation of the ileocholic artery. So it is an end artery. If there's now that is the reason why appendicular necrosis happens. So with inflammation, the appendicular artery gets clogged. With inflammation, it forms a thrombus in the appendicular artery and it blocks. And with that block, the distal ischemia happens, and there's ischemia to the distal appendix. And with appendix ischemia, it will cause gangrene, and ultimately it will rupture. That is why appendicular perforations are common in the tip rather than the base. So that's because of the end artery ischemia. So that is also true. So answer true, 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 false, true. Okay. Okay. So regarding fractures, Smith fracture results in volar angulation of the radius. So what is Smith fracture? So Smith fracture is basically reverse Colles fracture. So in Colles fracture, there's dorsal angulation forming the dinner fork deformity. Basically, the arm is like this, causing dinner fork deformity. But in the Smith fracture, is the exact opposite. It's called dorsal angulation. It is happening when the patient falls on an flexed hand. Patient basically fall like this, and basically it's just basically there's fall, there's fracture here, and the entire segment displaces anteriorly. So volar angulation, volar means anterior, of the radius is called Smith fracture. That is true. So if you can show you image, this is the Smith fracture, how it occurs, and with that there's an anterior dislocation of the distal segment of the fracture. Okay. The fractured neck of the femur results in external rotation of the lower limb. Yes. So neck of femur fractures commonly present with shortened external rotated limbs. Okay. In contrast to posterior dislocation of the hip, where the limb is internal rotated, adducted, and shortened. Okay. So that so the difference between neck of femur fracture and posterior hip dislocation you should know. In neck of femur fracture, the limb is external rotated and shortened, but in hip dislocation, internal rotated and abducted and short. All right. Radial nerve is often injured in fracture of the neck of the humerus. Okay, it's not the neck of the humerus, it is actually the shaft of the humerus. If the neck of the humerus is affected, then then that is the axillary nerve that is being damaged, not the radial nerve. Radial nerve is damaged during the shaft of the neck, shaft of the humerus fracture, because the radial nerve spirals around the shaft of the humerus. All right. So it will cause wrist drop and finger drop growth. Bennett fracture involves the distal end of the radius, false. Bennett's fractures and Roland's fracture both are fractures in the proximal part of the first metacarpal bone, involved in the intra-articular fracture of the metacarpal proximal end of the first metacarpal bone. So that is false. Supracondylar fracture of the humerus can cause arterial damage. Yes. Now, now this is a Bennett and Ronald fracture. You can see the first metacarpal bone where the fracture is there, and then this is the supracondylar fracture. Now you can imagine. Now you can see there is anterior dislocation of the proximal segment, and the artery travels in the anterior part of the arm. So now this anterior dislocation can cause laceration of the artery or even kinking of the artery. Then that can cause arterial damage and distal ischemia. So this is an vascular emergency, and we need to reduce the fracture and explore the artery. And if there's associated damage, we should either reconstruct it with end-to-end anastomosis or with a reverse venous graft. So that is the management. So this also true. So answers are true, true, false, false, true. Okay. Okay. Which of the following are voiding symptoms? Okay. When we talk about LUTs, so this how they ask about LUT symptoms. So when you talk about LUT symptoms, there are two types: voiding and storage. When you pass urine, there are voiding systems. When you store urine, there are storage symptoms. So what are the voiding and what are the urine storage symptoms? So the voiding symptoms, if we start from the beginning, the patient will have strangury. So what is strangury? So it's like tenesmus. Basically, the opposite, basically urinary part of tenesmus. You have the urge to urinate, but when you try to urinate, there's nothing coming on. That's called strangury, because then obstruction. There's bladder distension. So you feel the urge to urinate, but actually you can't because there's an obstruction. So there's strangury. And hesitancy. You try to urinate, but no, nothing is coming out. Hesitancy. Straining. Now, when you feel there's something, you will strain. You will tense the abdomen and try to squeeze. With straining, the pressure increases and this obstruction may be relieved. And then on a stream comes, but the stream is poor. It doesn't like jet off. It's a poor stream, slowly coming. Okay, and it's an intermittent stream, like breaking. It will come part, then break, and again part will come, again break, and again part will come. Intermittent stream, and again the stream will be happening for long time. Small, so like weak stream, intermittent stream for long time. For example, 1 to 2 minutes. So long duration, and at the end it will keep like dribbling, like drop by drop. It will keep dribbling for long time, and even after you finish urination and come out, the underpants will be soiled with terminal dribbling. And even though you emptied your bladder, you will still feel there's some amount of urine left inside. No matter how much you try, it doesn't come out. Incomplete emptiness of bladder. So those are the voiding symptoms. If you remember these in the order, then you can just nicely tell it like a story. Okay. So what are the voiding symptoms, storage symptoms? Frequency. Now imagine you urinate, but you feel now not everything is lost. Some is left. So the ability of the bladder to accumulate urine is reduced, because now imagine the bladder can accumulate around 400 milliliters of fluid before you feel the urge to definitely urinate. So imagine now you urinate, around 90 milliliters is left. So the bladder can only accumulate another 310 milliliters. So the frequency of you have to urinate is increasing. So frequency increases. Nocturia. So in the night also you will have to go more than 2 times. More than 2 times you have to go. It's called nocturia. Urgency. When you get the need to go to the urine, you have to go. You can't wait. You can't hold. Okay, that's urgency. Urge incontinence. When you get the urge, you can't wait for long. If you wait for long, you will just go in your pants. That's called urge incontinence. And enuresis, nocturnal incontinence. Sometimes in night, you won't feel the pain. Sometimes you just soil your pants and the bed. Called enuresis. So those are the storage symptoms. Okay. So let's have a look at the questions. Voiding symptoms frequency, false. Urgency, false. Overstream, yes. Strangury, yes. Hesitancy, yes. So false, false, true, true, true. Okay. Okay. False, false, true, true, true. Which of the following are causes for diarrhea? Ulcerative colitis, hypothyroidism, verapamil, carcinoma of the rectum, acute appendicitis. So ulcerative colitis, yes, it is one of the most common. What is the commonest presentation of ulcerative colitis in exacerbation is called diarrhea. Bloody diarrhea is the commonest complaint. So it is true. Hypothyroidism, no, as we discussed, hypothyroidism causes constipation. It is hyperthyroidism that causes diarrhea. So it is false. Verapamil, it is a calcium channel blocker. So what happens with calcium channel blockers? The calcium, with no calcium, the contraction cannot happen. So what happens? There is constipation. The peristalsis is not occurring properly. So verapamil is a calcium channel blocker. So it causes constipation. So it is not a cause for diarrhea, it is a cause for constipation. False. Carcinoma of the rectum, yes, carcinoma of the rectum can cause diarrhea also. It is called altered. It can cause either constipation, either diarrhea. It can cause either way, depending on the level of obstruction. And it can cause sometimes altered bowel habits. Sometimes it causes constipation, sometimes it's called diarrhea. Because constipation with constipation, the fecal mass will accumulate. With accumulate, there will be active bacterial overgrowth. With that, the feces will undergo fermentation, and with this fermentation, there will be fluid accumulation, and ultimately, it will pass as diarrhea. And again, constipation will occur like that. Okay, so it can also present as carcinoma of the rectum as diarrhea. Acute appendicitis, yes, if it's a long appendix, and the tip is in the pelvis, and it is palpate and it is touching the sigmoid colon and the rectum. Yes, if there's inflammation, it can irritate the rectum and cause diarrhea. It is true. It can even if it irritates the bladder, it can cause dysuria also. So those are common symptoms of not common, uncommon symptoms of acute appendicitis, diarrhea, and dysuria. So answers are true, false, false, true, true. Okay. So stomach cancer. So stomach cancer, what are the clinical features? So early satiety, abdominal distension, bloating, upper GI bleeding with features of iron deficiency anemia, dysphagia, and weight loss is very characteristic for gastric carcinoma. You know, weight loss and loss of appetite, very characteristic for gastric carcinoma. Apart from gastric carcinoma, weight loss and loss of appetite is associated in pancreatic carcinoma, gastric carcinoma, and cholangiocarcinoma. So those three are very notorious for causing weight loss and loss of appetite. So remember that. It can cause dysphagia, and it can also cause a symptom called Croce's syndrome. Croce's sign is called. It develops thrombophlebitis in the superficial veins. It occurs as a paraneoplastic reaction. Okay. So let's look at the MCQ. Bile staining omitting in the majority. No. So why would stomach cancer cause bile staining? So stomach cancer can cause gastric outlet obstruction. Then there's absolutely no bile staining vomiting. So bile staining or vomiting happens if there is obstruction distal to the ampulla of Vater. Now in gastric carcinoma, there is no obstruction distal to the ampulla of Vater, so the bile can easily go to in the least resistant path. You don't have to vomit out. So that is false. Dysphagia, yes. If the gastric cancer involves the cardiac and the fundus, yes, it can involve the GOJ and it can cause dysphagia. It is true. Transcoelomic spread to the liver is in majority, not in majority, but it's an but if it breaches the serosa, then it can cause transcoelomic spread to anywhere, liver, omentum, other places in the peritoneum, umbilicus called sister Joseph nodule, and the Douglas pouch where ovaries are affected called Krukenberg tumors. So those are all transcoelomic spread. So majority false. Sister Joseph nodules, yes, can cause. So transcoelomic umbilical nodule. Perforation, yes. If it's ulcerating type gastric cancer, yes, ultimately it can cause perforation and it can cause peritonitis and gas under the diaphragm. And patient will present with acute abdomen with tender wooden board stomach. Okay, so answers are false, true, false, true, true. Okay, okay. So investigations done to assess local spread in esophageal carcinoma. So when you assess the local spread of the esophageal carcinoma, the options are the ultrasound and the MRI. Okay, those are the MRI gives us a very good evaluation of the soft tissues, and ultrasound also gives us a good evaluation of soft tissue, but not the traditional transabdominal ultrasound. The transabdominal ultrasound will not give us a good picture of local spread. So, but the ultrasound done with endoscopic ultrasound, or what do you call laparoscopic ultrasound, these two we will directly go to the lesion and scan the surrounding. Then we can obviously pick up the extent of the lesion, but not the transabdominal ultrasound where we scan over the skin of the abdomen. Okay, so MRI of the chest, yes, true. We can assess the local spread definitely. Abdominal ultrasound, no, not abdominal ultrasound. It is either esophageal ultrasound or laparoscopic ultrasound. So abdominal ultrasound is false. It is not done to assess the local spread of esophageal carcinoma. False. Transesophageal echo. Now echo we are doing not to assess the local spread, we are doing to assess the cardiac status. So it is false. Endoscopic ultrasound, yes, true. We can endoscopic ultrasound. We can do endoscopic ultrasound at the site of the lesion. So we can assess how much of a depth is the lesion, and stage called the TNM classification, T classification. Whether the submucosa is involved, muscularis level is involved, beyond that adventitia is it involved, like that we can assess. And laparoscopic ultrasound, yes. Endoscopic ultrasound, yes. LFT. So LFT will not give us an idea about local spread. It will give us an idea about whether the liver is involved, but other than that, not. So it's false. So answers are true, false, false, true, false. Okay. MRI says true, abdominal ultrasound false, echo false, endoscopic ultrasound true, LFT true. All right.
Yes, sir.
Clear? Okay, very good. So question number 25, the last question. Which of the following suggests strongly for vascular damage in a young patient who comes to the emergency department following RTA? So RTA, young patient, vascular damage. So young patient, that means there's no history of peripheral vascular disease. The arteries are patent. Then RTA, and vascular damage. So what are the features of acute limb ischemia? So this is a traumatic acute limb ischemia. So what are the features? There are 6 features. So they are, that is them. There's pain, pallor, perishing cold. It's called perishing cold, not just cold. Pulselessness, paresthesia, and at last paralysis. Depending on this, we classify the limb according to Rutherford Morrison classification. There are three grades: 1, 2B, 2A, and 3. Depending on that, we determined our management. Okay, so these are the pain, pallor, perishing cold, pulselessness, paresthesia, and paralysis. Okay, so let's have a look at our MCQ. Sudden swelling of the limb. Yes, if there's arterial injury, there could be a hematoma. Hematoma can expand rapidly. Arterial hematoma can expand rapidly. So sudden swelling of the limb, and it can cause compartment syndrome also. So it can be a feature of vascular damage. It can be assessed true. Unilateral absent pedal pulse. Yes, this is a young patient. In a young patient, the pedal pulse would be there's sometimes the young patient can have absent pedal pulse because of vasculitis, but majority will have. So absent pedal pulse may suggest strongly. The young patient, yes, you can have a suspicion of acute limb ischemia with traumatic acute limb ischemia in a patient who does not have absent pulses in the dorsalis pedal pulses. True. Hypertension. Yes, imagine this is a open compound fracture. Imagine Gustlow Anderson 3C, that is open fracture, more than open fracture with vascular damage that needs intervention. So vascular damage means there's bleeding, that there can be external bleeding, and this can cause hypovolemia. Yes, it can. There can be. We can we can have suspicion. That's also true. Cold limb, as I said, perishing cold limb is a feature of acute limb ischemia. So true. Fracture of the shaft of the femur on X-ray. So uh, so fractures of the shaft of the femur is not usually associated with arterial injury. It can associate very high velocity, very traumatic injuries, but just because there's a fracture of the shaft of the femur, that is not a reason for us to suspect acute limb ischemia. We have to examine other pulses and other features and determine. But just because there's a fracture in the shaft of the humerus, no. But imagine there's a fracture in the distal femur, distal femur, or fracture in the proximal tibial plateau. Then, yeah, then we should definitely suspect there could be there's a high risk of having a popliteal artery injury. So in that case, we should examine the distal pulses and examine features for acute limb ischemia and look at the saturation. We should look at the saturation of the foot. We should look at the capillary filling time of the limb. And if these are all affected, then there's a high chance of limb ischemia. If there's a doubt, we can obviously do a CT angiogram. If there's no doubt, clinically it's obviously look like a acute limb ischemia, then we should obviously explore with the orthopedic team after they fix the limb with the external fixator. Then we have to explore the artery and do a end-to-end repair or graft repair. So that is, so this answer is false. Fracture of the shaft of the femur is false. So true. Last question, last MCQ is, last stem is false. Did you understand?
Yes, sir.
Yes, sir.
All right. Okay. So that brings an end to our MCQ discussion. Now there are some SBS left. So I can continue this discussion until about 12. At around 12, I will have to go for some work because there's going to be aortic aneurysm exploration in the theater at around they will start at around 12. So I will have to go by that time. Until that time, we will discuss few SBS. Shall we do like that? You have around 20 minutes time. Or do you want to sign off? Guys, what do you think?
We can check a few SBS.
All right, very good. Love the attitude. Okay. An obese female underwent a left hemicolectomy and presents with day 5 fever, BP 110/70, Pulse rate 64 minutes and regular. Abdomen is tender but soft. She has a past history of myocardial infarction and is currently on aspirin and atenolol. Chest is clear. What is the most likely diagnosis? So this is a condition with post-operative fever. So when you talk about post-operative fever, depending on the day of the fever, there are different possible etiologies. So I know you must have heard of the mnemonic wind, water, wound, walking, wonder. Can you remember the mnemonic? Have you heard of that? Hello?
Yes, sir.
Yes, sir.
Yes. What is wind? Wind is air. Air means lungs. So immediate post of day 1 fever, most of the time it could be due to some respiratory tract infection. Maybe the patient, maybe there's because of the basal atelectasis, or maybe due to a trauma. If this traumatic injury that needs surgery, it can cause pulmonary contusions like that. Some problem with the respiration. So pneumonia, basal atelectasis like that. That is the most common cause for day 1 fever. So day 2 to day 3. So and day 1 it also could be wonder. So what is wonder? Drug induced. So example, succinylcholine that is used to induce paralysis in our general anesthesia. It can also cause a malignant hypothermia that can also manifest as a fever. So day 1 fever, that malignant fever actually won't be day 1, it will be day 0. After surgery, he will be having this malignant hypothermia. So, so drug induced, it's called wonder. Okay. Then comes the water. So what is water? Urine. So urinary tract infection. Day 2 to day 3. So that is the usual time that urinary tract infection manifest. But it can manifest even later. But that is the most common time to manifest. You know, when we do major surgeries, we catheterize the patient. So catheterization is where we insert a foreign body into the urinary tract. So by doing that, we can inadvertently introduce bacteria to a sterile urinary tract. So that can cause UTI. So day 2 to day 3, like this is the time of urinary tract infection development. Then comes wound. The wound surgical site, that is surgical site infections, can be broadly categorized into 3 parts: superficial, deep, and organ space. So superficial is what? Superficial is basically from the skin to the deep fascia. So what is the deep fascia? For example, if you take a laparotomy incision, the skin up to the rectus abdominis, rectus sheath, skin to the rectus sheath is the superficial surgical site infection layers. And then in the abdominal muscles from the rectus sheath to the peritoneum is the deep surgical site infection. And then the organ space infection, surgical site infection is intra-abdominal, intraperitoneal abscess or collection or peritonitis or something. That's called deep organ space surgical site infection. So superficial surgical site infections will manifest in around 3 to 5 days, but deep space infections will manifest around 5 to 7 days. Okay, good idea. Okay, now we talk about wind, water, wound, walking, wonder. So what's left is walking. The walking is whatever walking is with the foot. That foot means is DVT. So DVT also can cause fever and it can cause pulmonary embolism. It also. So that usually manifests after day 5 to day 7. That is the period that deep venous thrombosis. But in our population, Sri Lankan population, the DVT is very low occurrence. This is very common in white people, Caucasian peoples. Even they become immobilized for jet travel. In flight travel, they are immobilized. Their lower limbs are in a constant regular position. That is also enough for them to have a DVT. Sometimes they go in a jet, they get down at the airport and walk a few steps and then die on that because of the pulmonary embolism. It's like that severe in there. But in our population, we don't encounter pulmonary embolism like that. But it is not unseen, can occur, but very rarely. But we have to keep in our mind this could be pulmonary embolism and DVT. Okay, so let's look at this patient. Okay, so this patient, what we are saying is day 5 fever. So day 5 fever, BP is okay, pulse rate is also okay, abdomen is tender but soft. She has a past history of MI, currently on aspirin, and chest is clear. So wind is out. Day 5 means this could be a surgical site infection, or it could be a DVT, it could be even a UTI. But this abdomen is also soft. Abdomen is also tender. Okay, so this could be something like a surgical site infection. So when there is the important message for you to learn in this MCQ is, if there's an anastomosis constructed, unless proven otherwise, post-operative fever could be due to anastomosis leakage. So that is a very important concept too. So we have to first of all exclude anastomotic leakage. Once you exclude that, you can exclude other problems, because anastomotic leakage will kill the patient first, then other things. So unless proven otherwise, in a patient who has had anastomosis, the patient we should suspect anastomotic leak, and it's day 5 also, very ripe for anastomotic leakage. So answer is B, anastomotic leakage, not MI, not ataraxis, not pulmonary embolism, not acute ventricular fever. Okay, understood?
Yes, sir.
All right, very good, super. So next question, young woman presenting with ulcerated fistulating lump on the lateral aspect of her neck, anterior to the sternocleidomastoid muscle for 4 weeks. Preceding the ulceration, there was a matted lump for 6 months. She has complained for episodes of fever towards the evening. Her condition is likely to be. So I think this is a very easy question. So evening pyrexia, long duration of matted lumps, and matted lymph nodes with ulceration. So what is this? This is a collar stud abscess, right? What is a collar stud abscess? It's a tuberculous lymph node, ulcerated tuberculous lymph node. It's called collar stud abscess. That's the name given to this condition. Okay, so the answer is B. I think there's no doubt regarding that, right? Anybody, any doubts regarding that? I think that's a very simple question. Anybody? Anybody? No, right? Okay, we'll go forward. So 25-year-old who met with an RTA comes with maxillofacial injury, subcutaneous emphysema of the neck and chest injury. Patient is in respiratory distress, trachea is deviated to the left and reduced breath sounds on the right. He is pale, confused, but calls out for water. Which of the following is the next step? So let's have a look. So airway, now is the patient, now we assess the patient in ABCD, in a primary survey, ABCD approach in our ATLS guideline. So airway, is it okay? The patient is asking for water. That means he can talk. So the airway is patent. Okay, what about the respiratory? There is subcutaneous emphysema. Okay, then there's respiratory distress. Trachea is deviated to the left with reduced breath sounds on the right. So what is this? This patient is having a, anybody? Can you tell? Anybody?
Right side tension pneumothorax.
Yes, you are very correct. This is a right side tension pneumothorax. So this is a medical, so it's an emergency. We have to relieve this tension. Okay. So then what about the circulation? He's pale and confused. So what do you think this patient having? Hemorrhage shock, right? Neither. Hemorrhage shock. So what degree? What do you think? Grade 3 or 4? What do you think? This is grade 3, right? Because he's confused, not lethargic. He's actively asking for water and pale. Confusedness, so it's grade 3. So there's multiple problems with this patient. So what are our options? So what is the next? They are asking next step. So patient cervical spine immobilization tracheostomy. Yes, cervical spine immobilization, yes, we should do, because the patient comes with the maxillofacial injury. there could be obviously there could be a suspicion of what do you call me cervical spine injury. So cervical spine immobilization should be a must. But tracheostomy, why? Airway is completely patent. And even though even if the airway is not patent, tracheostomy is not our next. Our next will be oxygenation with chin lift and jaw thrust with oral airway, and once the saturation is acquired, then we go for endotracheal intubation, not tracheostomy, right? So that is completely out, false. Cervical spine immobilization, right side thoracentesis. Yes, that is an acceptable answer. Good. Let's go to the other answers. Right side thoracentesis and blood transfusion. Yes, these are indicated. But what is first to be done? Is cervical spine immobilization should be done first, right? Because A, B, C, D, and A is airway and cervical spine immobility. That should be done first. Water seal drainage and blood transfusion. So there's no point of doing water seal drainage without doing a thoracentesis first. That is also out. Blood transfusion, yes, you definitely have to do blood transfusion. Left side thoracentesis and blood transfusion. Yes. No. Why do you don't need to go left side? This problem is right side. No, not left side. So that answer is completely wrong. So our doubt is between B and C, right? So why? So answer is B, because we should do the cervical spine immobilization first, because it's the ABCD approach. But telling this is even though this is called sequential, this everything is happening in an or parallel together. Even though it's a sequential, everything is happening parallel. Somebody will provide cervical immobilization, while somebody will go and do the needle tracheostomy. Okay, so everything happens parallelly. So, but theoretically, cervical immobilization comes first. So the answer is B. Okay, understood? Okay. So 25-year-old man present with recurrent intermittent jaundice for 2 years. On examination, he presented with enlarged jaundice with enlarged spleen. On one episode, he had fever, abdominal pain, nausea, and vomiting, and looked very much anemic. And now he has slight jaundice, enlarged spleen, and superficial 3 centimeter ulcer on the leg. What is the most probable cause? So he has intermittent jaundice and enlarged spleen. So what does this tell us? Is it a pre-hepatic, post-hepatic, or hepatic jaundice? Come on, somebody, I need to answer. Anybody? And he's anemic also. Come on, somebody answer. Anybody? What do you think this is? Is it a
Hemolytic
post-hepatic?
jaundice. Pre-hepatic.
Yeah, very good. This is a hemolytic prehepatic jaundice. Yeah, because there's splenic enlargement, anemic, and intermittent jaundice. Okay, so and on one episode he had fever also. So and now they are saying there's a superficial 3 centimeter ulcer in the leg. Now hereditary spherocytosis patients, they have highly their RBCs are very highly fragile. Like osmotic fragility is high. They can't handle stress. So in a fever, in episode of infection, this blood cells undergoing stress will easily fragment and cause hemolysis. And this hereditary spherocytosis is also associated with lower limb edema, also lower limb ulcers. So that is also that also can give you as a MCQ or even as a SBA here. So the answer is hereditary spherocytosis. Got the idea? You differentiate from ITP with that a superficial ulcer in the leg, because hereditary spherocytosis is associated with superficial ulcers of the leg. Okay, answer is B. Okay. So 6-year-old boy presented with pain and a limp on the left leg for 2 months duration. On examination, the adduction and the internal rotation was restricted. What is the most probable diagnosis? Development dysplasia of the hip? No, it is usually associated development dysplasia diagnosed in the infants, like neonates. So false. Perthes disease? Yes, can occur. Age is correct. presenting in the limb. Presentation is also correct. Adducted and internal rotated limb. So presentation, I think it is correct. Septic arthritis, 2 months duration, unlikely. It should be acute onset. So little bit off. Flipped upper femoral epiphysis, it is usually happening in the puberty period. In females a little bit earlier, 12 to 13, and males it's 13 to 14 like. So not the correct age. Osteoarthritis, unlikely in this age. Osteoarthritis usually seen in old age. So the answer for this is the Perthes disease. So Perthes disease is avascular necrosis of the femoral head. So that can cause with abduction and internal rotation along with pain and limb. That is how, and typical age is 5 to 6 years. And so the answer is Perthes disease. Okay, let's do one more question and we'll finish off the session. All right. So 45-year-old female had a lump on the side of the neck, which moves up with deglutition for 8 months. Then 4 months later had another few multiple lumps are seen. Which of the following is the most commonly likely diagnosis? Okay, lump on the side of the neck, which moves up with deglutition. So with swallowing, it moves up. So what does it mean? It is a thyroid lump. Okay, so it's the side of the neck. So it's a solitary nodule on the one side. Okay, and for 8 months, so longer duration. So cannot be anaplastic carcinoma. It's anaplastic carcinoma will not live for 8 months, and 4 months later, multiple lumps are occurring. So what can be these lumps? Newly occurring lumps. What can be these? These could be lymph nodes, right? Lymph nodes, that is metastasis. Okay. So which of the following is most likely diagnosis? Follicular carcinoma, papillary carcinoma, thyroid lymphoma, multinodular goiter. So multinodular goiter, unlikely. So follicular carcinoma. So how do you common mnemonic for follicular? So follicular ends with R. R is red. Red is blood. If you remember like that, it's easy. So follicular carcinoma metastasis is hematogenous. Okay. Follicular ends with R. R is red. Red is blood. And then papillary. Papillary ends with Y. Y is yellow. Yellow is lymph. So papillary carcinoma metastasis with lymph node. So what do you think the answer is? Is the papillary thyroid carcinoma, right? Yes, that is the answer. Okay, let's do next question also. Let's do 30-year-old female comes with features of anemia and also complaints of starry stools. He has been taking diclofenac sodium for chronic back pain for 3 months. Which of the following is most likely diagnosis? Now she's having anemia, okay, and melena. Anemia and melena. So this is upper GI bleeding, and she has taken diclofenac sodium. So she is taking NSAID. So NSAIDs are very is a risk factor for peptic ulcer disease and for some chronic back pain. What is the most likely diagnosis? Gastric atrophic gastritis, gastric ulcer, gastric carcinoma, GERD, esophageal varices. What do you think it is? It's an gastric ulcer, right? Gastric ulcer eroding into an artery and eroding into a vessel, which cause upper GI bleeding, which manifests as anemia and melena. Okay, good. So why does diclofenac produces cause gastric ulcers? Because it causes reduction of prostaglandin release. So prostaglandin is protective for, it's a product of arachidonic acid metabolism. If you remember your biochemical days, it is protective for the gastric mucosa. When it is not produced in adequate quantities, the protective function of the gastric mucosa declines and gastric ulceration is more likely. That is why in NSAIDs it's a risk factor for gastric ulcers. Okay, just we'll do one more also. Which of the following is least likely? Let me check. Okay, I maybe like 5 minutes I can wait. Which of the following is least likely complication for chronic pancreatitis? Which of the following is least likely chronic pancreatitis? Projectile vomiting, epigastric mass, cirrhosis, esophageal varices, cirrhosis, direct hyperbilirubinemia. Which of the following complication is least likely complication for chronic pancreatitis? Destruction, cirrhosis. So, projectile vomiting, what do you think? So, we'll leave projectile vomiting for time being. Epigastric mass, yes. As I said, pancreatitis has local complications like pseudocyst formation, which can manifest as epigastric mass. Obviously true. Esophageal varices, yes, because as I said, with chronic pancreatitis, there would be splenic artery thrombosis, splenic artery and splenic vein thrombosis. With splenic vein thrombosis, there would be hypertension in the gastric fundal veins. So that can cause fundal varices. Okay, so that can cause esophageal varices also. So that is true. Okay, that is a complication. Cirrhosis in chronic pancreatitis, not heard, very rare. I have never heard. Direct hyperbilirubinemia, yes. If with chronic pancreatitis, that's an inflammatory condition. With the inflammatory condition, there could be inflammatory masses in the pancreatic head region that can cause obstruction of the common bile duct. If the common bile duct is obstructed, there would be direct hyperbilirubinemia. That's a post-hepatic jaundice. So that is a that is a possible cause. Okay, projectile vomiting. Okay, imagine there's now this I said chronic pancreatitis can cause inflammatory masses. Now one of these inflammatory masses can cause gastric outlet obstruction also. In that case, it can cause, although rarely, it can cause projectile vomiting. So that's also a possibility. We can't say no. It is a possibility. But cirrhosis, it is unlikely, because cirrhosis to occur, there should be a problem. There should be repeated injury to the liver, but now the injury is in the pancreas. So how come it can cause cirrhosis? So yes, the least likely complication would be cirrhosis. So the answer would be D. Did you understand my thought process? So one body has asked, somebody has, sir, for the third one, is it? Answer is B. Third one, is it B? Yes, yes. Third one answer is B. Yes, that's true. Did you understand? Hello?
Yes.
Okay, good. Let's do one more. 65-year-old man presented with okay. Patient is on the way to theater. Okay, we'll see. 65-year-old man presented with worsening jaundice for 6 months. He has developed itching and weight loss for the past 2 months. Imaging studies done shows dilated intrahepatic ducts, intrahepatic ducts, and hepatomegaly. There is no extrahepatic duct dilatation. Gallbladder is not palpable. Pancreas cannot be seen due to gas shadows. Bilirubin levels are increased to 220. ALP is reached to 1250. What is the most popular diagnosis? Okay. So, okay. So what do you think? CBD stone. Is it possible? There's no extrahepatic duct dilatation. If it is CBD stone, then the proximal CBD and the common hepatic ducts and the hepatic ducts, right and left hepatic ducts should be dilated. So those are extrahepatic ducts. So there's no extrahepatic duct, so it can't be CBD stone. Out. Hyalocholangiocarcinoma. Yes, this fits. Intrahepatic duct dilatation, but no extrahepatic duct dilatation. Gallbladder is not palpable because no bile is flowing to the gallbladder to increase. Bilirubin level is rising because it's a post-hepatic jaundice. ALP is rising because it's the pathology of the biliary tract. So it is nicely fitting. Cholangitis. Okay, if it's cholangitis, there should be history of fever. There's no history of fever, and there's no history of right side hypochondrial pain. So it's out. Mirici syndrome. Again, if it is Mirici syndrome, there should be at least Mirici type 1, the obstruct neck bile calculus at the neck of the gallbladder impacting on the common hepatic drug. Then there should be some degree of common hepatic drug extrahepatic drug dilatation. So it's also out. Periampullary carcinoma. In periampullary carcinoma, again, is basically at the ampulla. So there should be dilatation of the extrahepatic ducts. There's no extrahepatic dilatation. So the answer is hilar cholangiocarcinoma, or called cat skin tumor. Okay. All right. So 30-year-old man presented to the emergency department with loin to groin pain with blood tinged urine. What is the best investigation to diagnose this condition? So what is this condition? This is urolithiasis, right? There's urine stones, right? So we don't know where it is. It's probably in the ureter, loin to groin pain. So what is the best diagnosis? Confirmed diagnosis. CT-IVU, NCCT-KUB, USS-KUB, X-ray KUB, UFR. So the gold standard to diagnose kidney or ureteric stones or bladder stones is the NCCT-KUB. Okay, so the answer is B. NCCT-KUB is gold standard for detecting urolithiasis. Okay. Following an RTA, a patient presents with dyspnea and engorged neck veins. The BP is 80 by 50 millimeters mercury. Heart rate is 120 beats per minute. Trachea is in the normal position. Bilateral breath sounds are equal. Which of the following is most likely? So the patient is having RTA, tachycardia, low BP, engorged neck veins. Okay, so what is this? This is called Kussmaul's triad, neither. That is seen in where?
Cardiac tamponade.
Very nice to hear. Everybody saying the same answer. Very good. So this is a classical feature of cardiac tamponade. So how do you manage this patient? Initially, we should do the ABCD approach, assess the airway. Now airway seems to be all right and the breathing seems to be all right. Now the cardiovascular problem is the issue. So we should resuscitate the patient. Along with, we should decompress the pericardium. So we can't directly take the theater. So now patient is almost going to arrest. So we should do a needle ultrasound guided needle pericardiocentesis. We basically go through the diaphragm and enter the pericardium and aspirate the blood, and let the heart dilate a little bit to accommodate the venous return. And then once the patient is stable, we take to theater and do a thoracotomy, open pericardiotomy, and then repair the defect. Okay, that's how we manage. Okay, so another one we'll do. A 43-year-old male patient treated with cerebral abscess and is recovering well. No abnormality was detected except for low serum sodium. Plasma osmolarity low. Urine osmolarity is normal. BP is normal. There's no capillary peripheral edema. What is the likely diagnosis? So acute kidney injury, unlikely because no peripheral edema. Okay, and there's a history of cerebral abscess. Now the cerebral abscess and trauma is very commonly associated, and mycobacterium TB infections are very commonly associated with the syndrome called SIADH. Okay, so SIADH is called syndrome of inappropriate secretion of antidiuretic hormone. Okay, so that is the condition for this patient. Pituitary failure unlikely. excessive diuretic, there's no diuretic therapy, diuretic therapy, then the plasma urine osmolality will be low, not normal. Okay, so the answer is SIADH. Okay, all right, let's go fast because otherwise I might to go. So 30-year-old male patient presents with painless fresh rectal bleeding. History of constipation for 1 week is noted. What is the most probable diagnosis? Fresh PR rectal bleeding with constipation for 1 week. What do you think? This is the most common complaint given by a patient with hemorrhoids, constipation and PR bleeding, and some of them might say pruritus of ani. So this is hemorrhoids. Hari? If anal fissure, it will be extremely painful. Colorectal carcinoma at this age, unlikely. And constipation for 1 week, duration is not telling. Ulcerative colitis, yes, can occur. Can occur, but history of 1 week, unlikely. And constipation is not associated with ulcerative colitis, diarrhea mostly. And hemorrhoids, yes. Anal fistula, then it will be actually mucus discharge, not fresh painless bleeding. Okay. Let's do the next question also. 14. A 30-year-old patient has undergone a subtotal gastrectomy for gastric carcinoma. 3 hours after admission to the surgical ward, he presented with pallor, heart rate 120, BP 190/60. Extremities were cold during examination. He has profuse sweating. What is the reason for the above? Cardiogenic shock, septic shock, hypothermia, anaphylactic shock. Okay. So, if it is cardiogenic shock, the heart rate should also be low, right? So, cardiogenic shock is not possible. Out. Okay. Hypovolemic shock, yes. Heart rate high, low BP, extremities cold, pallor. Everything tallies. True. Septic shock, if it is septic shock, the extremities won't be cold. It will be warm. Hypothermia, unlikely. If hypothermia, the patient won't be having profuse sweating, so unlikely, false. Anaphylactic shock, again, the patient's extremities would be warm, so unlikely. So that's also false. Okay. Now question number 15. 26-year obese woman underwent carpal tunnel syndrome decompression. What is the structure most likely to get damaged? Deep branch of the ulna, false. Ulnar nerve, false. Palmar branch of the median nerve, true, it can get damaged. Median nerve, yes, it is possible to damage, but we actually go in with the idea of protecting the median nerve, and we take very much care of protecting the median nerve. But true, it can get damaged. But the question is asked, what is the structure most likely to get damaged? But this palmar branch of the median nerve, we actually don't. We actually, even though we are supposed to protect it, sometimes it can get damaged and without but median nerve, we visualize it and we protect it and divide the flexor retinaculum. So it's unlikely the median nerve to get damaged, but the palmar branch of the median nerve, yes, it can get damaged. It supplies the skin over the palm aspect of the hand. Superficial branch of the ulna, that is nowhere near, false. Okay. All right. I think now I might have to go. I think around few questions is left. We'll start it in our next discussion. Start from there and go ahead. So I think I will have to go now. I think that the patient is almost in the theater and they will be giving the anesthesia soon. So thank you. Yeah, thank you. You are all very welcome. So just before I sign off, any questions? Any questions that you might have, I might be able to answer. Anything? Any questions? Okay, if you don't have any questions, any suggestions that you might have, any things that you have noted that I might have to improve in my lectures so that it would be beneficial for you. Any suggestions? The internet connection was a little bit on and off, that's true, but I think when I brought the router near me, it became all right. Anything? So I think our admins will give you a feedback form. So if you have any suggestions, just mark it and let me know. Give it to our admins. They will hand it over me. So thank you so much for waiting with me until around 12:20. So I think you will hope you will have a nice night. I will be will be awake for quite some time now. So all right, thank you for so much. Then have a good night. All the best to everybody. All right,
Thank
good
you,
night.
sir.
Thank you, sir. Good night, sir.
Good night, sir.
Thank you, sir.
Okay, okay, okay.